Good morning, everyone, and welcome to Reach Out and Read of Greater New York's annual conference. My name is Emily Marchese, and I'm the Executive Director of Reach Out and Read of Greater New York, and I'm so proud to welcome you all here today. In our nearly 25-year history, we have grown to serving over 250,000 children every year in all 5 boroughs and beyond, providing books and early literacy guidance and linkages to families across the city. At every well child visit between 6 months and 5 years old, which is on average about 10 appointments, the Reach Out and Read medical professionals provide anticipatory guidance to families on reading to their child at home. And in each of those appointments, families receive a new, developmentally appropriate and linguistically appropriate book to begin building their home library. For many of the families we serve, the books they receive through Reach Out and Read are the first and only books at home. And for this reason, it's become more important than ever for us to provide diverse, bilingual books in the many languages represented across New York City. Through our Book Buddies Coalition, we're able to join with other early literacy organizations, leveraging our book budgets together to access volume discounts for the titles we want. This spring, we're placing an order for 200,000 diverse titles that will be shipped across our city, and we're able to order these beautiful books and hold today's conference free of charge to our community through the limitless support of our incredible donors, including the Pinkerton Foundation, the Overdeck Family Foundation, New York City Council, the Elks Foundation, and our incredible board of directors. And I want to personally thank Jack Pace, Jenny Gilmore, Josh Green, and Leora McGillner for their profound support of Reach Out and Read of Greater New York and today's conference. A few months ago, we welcomed a new board member to Reach Out and Read of Greater New York, who is also a site director at one of our wonderful sites. Whenever she pictured the Reach Out and Read team, she pictured a whole office floor filled with people busily typing away in their cubicles, answering phones, leading trainings. She couldn't believe that there are only 6 of us, and we're actually hiring right now. So right now there's only 5 of us. And honestly, some days I can't believe it myself. This conference today would not be happening without the above and beyond hard work and dedication of Jessica Lizio, our Senior Manager of Medical Engagement, and her wonderful team, Nardine Kella, Senior Associate of Medical Engagement and Data Analysis, and Veronica Hitchin, Program Coordinator. I also want to introduce and thank Sejal Kathari, our new Senior Manager of Books and Literacy, who is working on ordering those 200,000 diverse books that I mentioned earlier. The truth is, being around all of you, your wonderful sites, clinics, and hospitals, we never have to go too very far to be inspired to bring our best and brightest selves to Reach Out and Read and push for more for our families. So thank you for all that you do for our families and for giving us the opportunity to work with you. We have a wonderful agenda for you all today, and this is just the beginning of the discussion. So while we're going to keep to our schedule to be respectful of everyone's time, know that all the contact information of the team and the panelists will be shared, and we look forward to continuing to dialogue on these issues at our upcoming town hall and more. We're also excited to see many of you at our cocktail hour and award announcement tonight. We're actually all sold out for tonight. So if you did not register, we are unfortunately closed, but please feel free to use the Q&A and the chat throughout the day at the conference. Our team will be monitoring it for your thoughts and questions. And now I have the honor and privilege of introducing Dr. Leora McGillner. Dr. McGillner is the Vice Chair of the Board of Directors of Reach Out and Read of Greater New York. She's also our Medical Director and Site Director of the Reach Out and Read program at Mount Sinai Hospital. She is a founding board member of Reach Out and Read of Greater New York and also serves on the National Board of Reach Out and Read. And those are only the things that she does for Reach Out and Read. Leora's leadership, guidance, and friendship has been one of our organization's greatest strengths. There is no one in this city, and likely much further than that knows more or cares more deeply about Reach Out and Read, and we are very grateful to have her joining us today and kicking off our annual conference. Leora, thank you.
Good morning. Thank you, Emily. I think you went a little over the top, but thank you. Good morning, everyone. My name is Leora McGillner, and as Emily said, I'm Director of Reach Out and Read at Mount Sinai, and I'm also Medical Director of Reach Out and Read of Greater New York. And I have to say, it's so amazing to see so many familiar names and faces on the Zoom, and also see new names and faces as well. So I first want to start by thanking the incredible staff of Reach Out and Read of Greater New York for putting together today's event. The staff at ROR has worked tirelessly, as they always do, to create a conference that we hope will inspire and educate you. I wanted to also recognize all of the staff members for the support and encouragement they show all of us at the sites all the time. And I particularly wanted to give a shout out to Jessie Lizio, who has worked so hard on today's event. Jessie, I can't wait for you to experience Reach Out and Read yourself as a parent soon. So I wanted to give a little background and context as to how the focus on today's theme, social determinants of health, came about. Those of us who practice Reach Out and Read know the profound impact that Reach Out and Read has on children and their families. The smiles we get from our patients and their families, the letters we get from parents telling us how much receiving a book and counseling has impacted their lives, and the connections that Reach Out and Read enables us to build with the families we serve speak for themselves. I will say, though, that it has been incredibly gratifying in recent years to read the policy statements and position papers which specifically call out Reach Out and Read and underscore the important role that ROR and other organizations play in child and family health and development. And I mean policy papers from the American Academy of Pediatrics and other respected pediatric groups and thought leaders. So in 2016, the American Academy of Pediatrics put out a policy statement on child poverty and recommended screening for social needs in practices and providing resources to address the needs identified. The statement specifically identified models of care in the medical home that promote effective parenting and school readiness, such as Reach Out and Read, we were first, HealthySteps, and VIP. Moving ahead a few years, the AAP put out another policy statement, which you may have seen, called Preventing Childhood Toxic Stress, Partnering with Families and Communities to Promote Relational Health. We all know about the adverse impact that ACEs, or adverse childhood experiences, can have on a child's growth and development. SSNRs, or safe, stable, nurturing relationships, are the antidotes to childhood adversity and toxic stress responses. And relational health is the ability to form and maintain these SSNRs. Not only do SSNRs buffer adversity and turn potentially toxic stress responses into positive responses, but they are also a strong vehicle for building those foundational resilient skills that enable children to cope with future adversity in a healthy, adaptive manner. The policy statement highlighted the need for multi-generational approaches that support parents and adults as they in turn provide those SS and Rs that all children need to flourish and succeed. The policy statement concluded by advocating for a public health approach that promotes relational health, is founded on primary prevention programs such as Reach Out and Read, and also highlighted the need for screening for barriers to relational health, such as maternal depression, food insecurity, housing insecurity, and other social determinants of health. Which brings us to the focus of today's conference. Today, we're going to be hearing about experts in the field of social determinants of health, who will speak about the role of social determinants in children's health and what we as pediatricians and advocates for children can do to identify and address social determinants in our practices. I will say that as practitioners of Reach Out and Read, we're already doing this every single day, but hopefully today will give us additional tools and resources that we can use to make this happen. So I'd like to now introduce our keynote speaker, Dr. Melissa Lutz, who I had the pleasure of meeting in person last week, a few days ago. Dr. Lutz is a fellow in general academic pediatrics at the Johns Hopkins University School of Medicine, and she serves as a clinical instructor at the Harriet Lane Clinic at the Johns Hopkins Children's Center. She received her MD from the University of Maryland School of Medicine and a master's degree in health sciences from the Johns Hopkins Bloomberg School of Public Health. She completed her residency at Children's Hospital of Pittsburgh. Dr. Lutz's research focuses on understanding and addressing social determinants of health in the clinical space, and she's dedicated to developing interventions to promote healthy lifestyles for children in her community. Thank you so much, Dr. Lutz.
Good morning. Thank you. It's an honor to be here today. I will go ahead and share my slides. One second.
Oh, Dr. Lutz, we will be sharing your slides for you if that's okay.
Oh, okay. Thank you.
Wonderful.
Perfect. Okay. Well, thank you. It's an honor to be here today, and I'm very grateful to have the opportunity to talk with all of you. For those of you who attended the Pediatric Academic Society's conference in Washington, D.C. over the weekend, where I met Dr. McGillner, you could see that this was a really hot topic, and there's a lot of fantastic up-and-coming research in this field. So today I'm hoping to provide somewhat of an overview of where we are and where we would like to go. And I know we probably have people here today who have a lot of experience as well, and I really look forward to having some meaningful discussion at the end of the presentation. So my objectives for today are as follows. First, to define social determinants of health and review the American Academy of Pediatrics policy statement that Dr. McGillner just mentioned. 2, to discuss various social risk screening tools. 3, explore potential interventions for addressing social determinants of health in the clinical setting. And 4, consider some of the risks and unintended consequences of social determinants of health screening and intervention now this is occurring more broadly. So first, defining social determinants of health. Social determinants of health are broadly defined as the non-medical factors that influence health outcomes. These are the conditions in which people are born, grow, work, live, and age, and are the wider set of forces and systems shaping the conditions of daily life. This is a definition that's actually shared by the World Health Organization and the Centers for Disease Control and Prevention. And as you can see on the right, the social determinants of health, or SDOH, fall into key domains: education, access, and quality, healthcare and quality, neighborhood and the built environment, social and community context, and economic stability. So in 2016, the American Academy of Pediatrics published a policy statement acknowledging the importance of addressing social factors in pediatrics. They state, because pediatricians work to prevent childhood diseases during health supervision visits and with anticipatory guidance, the early detection and management of poverty-related disorders is an important emerging component of the pediatric scope of practice. They recommend screening for social risk factors during patient encounters, and that pediatric clinics provide resources for those who screen positive. They list community-based organizations, federal and state programs, and programs that are integrated into the clinic that can be used to address these concerns, including initiatives that increase access to healthcare, healthy food, and safe and affordable housing. They also encourage pediatricians to advocate for public policies to improve the well-being of children. So, as we mentioned before, how does this relate to Reach Out and Read? So this statement outlines various strategies that work to ameliorate the effects of child poverty, including what they call family and parenting support in the medical home. They state, in a medical home adapted to the needs of families in poverty, parents have the opportunities and resources to promote resilience in their young children, giving them the capacity to adapt to adversity and buffering the effects of stress. They state they call for pediatricians to support integrated models of care in the medical home that promote effective parenting and school readiness, such as HealthySteps, Reach Out and Read, VIP, Incredible Years, medical legal partnerships, and the Positive Parenting Program. And as you all know, Reach Out and Read works. This slide is taken directly from the Reach Out and Read website, and I think it very nicely summarizes many of the positive impacts that the program has on childhood development, child-parent interactions, and school readiness. So as you can see here, there are more than 20 studies that show that parents are at least 2.5 times more likely to read with their infants, toddlers, and preschoolers. They're at least 2 times more likely to read with their children 3 or more times per week. Families are at least 2.5 times more likely to enjoy reading together or to have books in the home, and that children's language development is improved by 3 to 6 months. Children's language ability continues to improve throughout repeated exposure to Reach Out and Read, and as an added bonus, it improves clinic culture and clinician well-being. So now I'd like to discuss some of the various social risk screening tools that can be used. First, I would like to review the difference between social risks and social needs because there is a slight difference, although both fall into the domain of social determinants of health. So social risks are individual level adverse social determinants of health, and these are what we usually detect using screening tools. These differ from social needs, which are based on an individual's priorities and are often revealed through self-report or through discussion. And so the tools that we use are used to detect social risks and may not exactly reflect the needs that the patients have at that time. So I just wanted to make that distinction. So there are several social risk screening tools that are designed for use in pediatrics. These tools are generally intended to be completed by the parent or guardian, but there are tools that can be used for adolescents and young adults as well. In this table, it's adapted from an article by Henderson et al. In 2019, and then the Siren 2022 report on social determinants of health, and just summarize some of the key aspects of the commonly used screening tools. So the first one is the Health Lead Screener that was created in 2016, has about 10 questions. The iHelp tool, which stands for Income, Housing, Education, Legal Status, Literacy, Personal Safety Questionnaire, and that was created in 2007. The Medical Legal Partnership Screener, created in 2015. SEEK, which stands for Safe Environment for Every Kid, that was created in 2007. The SWIC, the Survey of Well-Being of Young Children, created in 2010. And the We Care tool, which stands for Well Child Care, Evaluation, Community Resources, Advocacy, Referral, and Education, created in 2007. So you can see some of these tools came about in the early 2000s and then a couple closer to the time of the policy statement. And these social risk screeners are designed to be brief, so they typically have fewer than 15 questions and are also intended to be accessible for a wide audience. Typically have a literacy level that's below middle school. However, some of them are more at a high school reading level, which is important to note. And they can be administered in various modalities, including on paper, completed verbally or electronically, and some have been translated into a few other languages as well. It's also important to note that some tools, such as the SWIC, actually have social risk screening questions incorporated into a larger screener that includes questions about childhood development and other aspects of the child's health. Some of you may be familiar with some of these tools or use these tools in your practice. Then on the next slide, this has some of the commonly screened domains that are in these tools. So this includes financial stability, education, food security, and the physical environment, which refers to housing, utilities, and the neighborhood. These, of course, are just some of the domains that can be screened for. Others could include depression, access to transportation, insurance, utilities, or risks that might be more specific to a patient population, such as citizenship for immigrant families. So as I mentioned, these screening tools can be administered using various modalities, but several studies have shown that parents tend to prefer paper or electronic screening tools to completing a verbal screening. Using a device such as a computer or a tablet is more private and can be easier and faster than completing the screening verbally. There are some newer innovations that allow for screening questions to be incorporated into the electronic health record or sent to patients prior to the visit that can simplify this process even further, but the effectiveness of such methods have yet to be published in the literature. So it's also important to decide how you're going to present the screener. So interest in receiving resources is actually higher when the purpose of the screening is explained before the screener is given. There's about 2 times higher odds of accepting assistance. And if you ask about desire for assistance before screening, there's a 1.5 times higher likelihood of interest in assistance. So it's really important that we're explaining why we're doing this to families and also asking if they want help. And despite the variety of screeners that are out there for use, some studies have demonstrated that there's often a disparity between the number of individuals who screen positive for social risks and actually seek or request assistance. This could be the result of our screening tools being ineffective or the way we're going about screening. So it's important we do this. We're very mindful about how we do this. So the social risk screening tools that are used, there's very little published data to support the validity of these commonly used tools. There was one study that looks at the WeCare tool as compared to the AHC, which is the Accountable Health Communities tool. And they found that while the WeCare tool, the inter-rater reliability when they looked at adolescents and adults was very high. So there's about 80% of concordance between the parents of the adolescents and the adolescents completing the tool. When they compare this tool to the AHC tool, they found that there was a discrepancy between positive screening results between the 2 tools. So people who said that they screened positive for housing on one tool maybe screened negative on the other tool, which really shows us that how we ask these questions is really important. And then currently, there's actually no gold standard for a tool, and there's not really a standardized tool used diffusely. So we can't determine sensitivity, specificity, or superiority of these tools. The current literature at the moment really just focuses on how practical these tools are for use. So given all of that, some practices may choose to create their own screening tool based on the questions that there are out there on these other tools. And so I wanted to show you the example of the tool that we use in our clinic, the Harriet Lane Clinic at the Johns Hopkins Children's Center. Our tool is called the Hopkins Community Connection Tool, and it's loosely based off the Health Lead screener that I mentioned a few slides ago. And our screener is not perfect. I will not say that it is, but I want to highlight some of the key features that we have here that are really important to include. So on the left, we have the questions about specific domains that are common needs that we've identified within our community through prior needs assessments. And then on the right at the top, we ask about resources and assistance for specific applications and services. And the key component on the bottom right that I really would like to highlight is we ask if you would like to receive assistance and if the needs are urgent, so we can better triage how we address these needs. And as I said, the screener is not perfect. We are a little inconsistent with our distribution, and a key component that I mentioned just a slide ago that we don't have here is a brief explanation at the top of the screener explaining why we're asking these questions. And we don't really have a standardized script for those who hand out the screeners to explain why we're doing this. So this is a future direction for us, but how we can maybe improve this and get better response rates in our clinic. So next, I want to talk about some potential interventions for addressing social determinants of health in the clinical setting. So regardless of whether a practice decides to use an existing screening tool or create their own, it's vital that they're prepared to respond appropriately to all risks identified. So we shouldn't be asking about something that we can't respond to. It's similar to how we wouldn't send a test in medicine that we're not ready to follow up on. And there are various types of interventions that require different levels of engagement from staff in the community, and I have divided these into 4 categories here. So the first are resource directories. The second are collaborations and partnerships. Third is clinic-based assistance. And fourth is our embedded programs. And I'll talk about these in more detail on the following slides. So first, at the most basic level, it's very useful to develop a database or directory of resources that can easily be provided to families. However, it's very difficult to keep up with changing availability of resources. So I highly encourage you to take advantage of publicly available regional directories and national resources that are already out there. So local AAP chapters, as well as your city or county or state health departments, often have a list of regional resources that are great to use and can be given to families. And a fantastic national resource is the United Way's 211, which you may be familiar with, can be accessed via their website, phone, or text. And individuals who are seeking assistance work with a United Way representative who can connect them to local resources. And this includes even urgent needs such as food or housing for that night. So that can really take some of the burden off of your clinic if you're looking for a quick way to connect families with a resource. CAP for Kids, which you'll see below, is a website that's designed and maintained by the Children's Advocacy Project. And that has a variety of social and developmental resources and parent printouts for 16 cities throughout the United States, including New York City. And so that's another great resource, and you can print out a sheet to give out to families at the end of the visit. And on the right here, you'll see Find Help and NowPow. And these are newer innovations. They're digital referral platforms that facilitate referrals to community resources and are gaining popularity in many hospital and healthcare systems. They allow the healthcare team to see if and when families are connected to resources, and they can actually be integrated into the electronic health records so that you can track this data. And as I said, these are newer innovations. They typically require a contract with the company, so they're usually better to be, purchased at a healthcare system. But you can go onto their website too and look at some of the resources and see how they work. So next, above resource directories, we have collaborations and partnerships. And it's really important that practices partner with their community, because not only will these help you to know what the needs are of your community, but can also help you to facilitate warm referrals so you can easily kind of connect a family with what there is in their own community. And this can come in various forms. It can be health departments, food banks and pantries, faith-based groups, and community development organizations. On the right here, I found this image on the Feeding America website, their page for Feeding New York State, that shows all the different food banks that are across the state of New York. I thought it was just a lovely image to show kind of every group's domain. So in addition to referring families to resources in the community or elsewhere, clinics may offer material goods, which is a really common practice in pediatrics. So, we offer things such as newborn items like diapers or formula. You can also have home safety items like car seats or helmets. And a really common emerging practice is to actually have food pantries within the clinic space. This is often non-perishable food that's available for families in clinic. And you can see the picture here of our food pantry. We have bags of non-perishable food. This picture is actually from a little while ago. We're shifting a little bit to have it set up more like a supermarket where families can go in and choose what they need, because we were finding that these heavy bags were not easy to transport and that a lot of the food was going unused. Some clinics also are setting up farmers markets on sites or have produce referral RX programs where you can go get produce from local vendors. So that's kind of a new up and coming intervention. And then in addition to actually handing out goods, you can provide services within the clinic space. So this could be assistance with legal and tax services. You can help families sign up for SNAP and WIC, get their benefits through the temporary assistance for needy families or the child tax credit, et cetera, when they're actually there in the clinic space instead of having to go elsewhere to do that. And then in addition to some of these more informal services, there are also several nationally recognized programs such as Reach Out and Read that can be embedded within the clinical space to provide specific services. So there's also HealthySteps for childhood development, and then something we often don't think about, but the medical legal partnership can help families right there on site. So I've included this image here. This is from a commentary that came out last year by a group at CHOP. that shows, unfortunately, while we wish the process from screening to referral were just a linear, straightforward process, it often should actually be conceptualized more like a funnel. So from all the families who are eligible to be engaged with resources, those who are actually engaged is quite smaller. The number is quite smaller. And so this can happen, they kind of get funneled through at various levels, starting from who even shows up to the clinic to be screened, but then various societal, community, and other barriers that are kind of stand in the way to getting resources. Just something we should think about, that we're being really intentional about how we're providing resources to our families and try to eliminate these barriers along the way if we can, so that we are not further magnifying inequities that exist in the system. So this brings me to my next point, the importance of following up with families. So it's one thing to provide resources, but we really need to make sure that they're able to follow through. There are, of course, many barriers that I'm sure we're all familiar with that can prevent families from receiving the resources. So they could have missed phone calls or appointments, lack of transportation or childcare that prevents them from getting to where they need to go, or just time constraints in general. So not shockingly, many studies have found that it's easier to be connected to resources when there are immediate solutions available and a direct pathway to get them. And one great way to do this is to actually integrate these interventions into the healthcare system. So one effective strategy to reduce those who are lost to follow-up is what we call linking services. So this can be volunteers, care coordinators, case managers, community health workers, et cetera, who help families connect to the resources. And these have been shown to actually decrease healthcare utilization by decreasing the risk of hospitalizations and increasing adherence to well child care. And previously or traditionally, this was thought of as an in-person service that takes place within the clinic. But of course, in light of the COVID pandemic, we've experimented with newer, more innovative ways of doing this. So these services could actually also be virtual. You could be following up by telephone or by Zoom, et cetera. And in some cases, even prior to the pandemic, families have preferred to receive text messages or emails to actually going in person to receive these services. So just something to keep in mind, it doesn't have to be a person who's sitting in the clinical space. It could be people who are following up over the phone or virtually. So an example of an effective linking service is the original Health Leads model. Some of you may be familiar with Health Leads, but they no longer actually use this model or support this model. So it's been adapted by various practices, but it's a model that works pretty well. So the way it works is that patients are paired with a resource navigator or an advocate after social needs are identified. And this advocate works with the patient to link them to resources, creates an action plan, and then discusses next steps, and then follows up with the patient every 7 to 10 days until their needs are met or until the family chooses to leave the program. And these advocates are actually typically undergraduate student volunteers who undergo intensive training and then attend weekly meetings to keep them up to date. And then above them, you can have program coordinators at each site where this is happening. If it's only at one site, of course, you could just maybe have a program manager, but they oversee the day-to-day operations and supervise these advocates. At the very top, as I mentioned, if there are multiple sites, you can have a program manager who oversees all these clinic sites. And so while the advocates are volunteers who are usually very eager to help, the program coordinators and managers are typically hired positions. And just to give you an idea of how this works at the Harriet Lane Clinic at Johns Hopkins, so we previously had a Health Leads program, but this was transitioned in June of 2019 to what we call Hopkins Community Connection. And we have desks at multiple clinic sites across our network, and each of these desks serve over 1,200 families per year, which I think is pretty impressive. And this data you'll see here is a little bit old. It's actually from prior to the pandemic, but it shows the commonly expressed needs within our patient populations. And you can see that housing, food, health are up there as high needs, and that's stayed pretty consistent. But also note we have different patient demographics in the communities at each of these clinics, and so the needs do vary a little bit by community, and it's just important to make sure we're tailoring our services to those communities. And as I mentioned, using these sorts of services can really decrease healthcare utilization, which can be a great way to build this to your health system if you're trying to get this started. So this was an article that was published last spring by a group at Hopkins, and they looked at families who enrolled in Hopkins Community Connection from June to August of 2018 and assessed healthcare utilization for 12 months following enrollment into the program. And in their analyses, they found that those who were connected with resources didn't actually have a difference in ED visits, but had fewer hospitalizations. And those who were connected to resources were more likely to attend their well child visit. So another option, if maybe having a linking service is not an option that's available to you, or if you have families who are pretty savvy and like to do this on their own, is using and promoting self-navigation. So providing support for families to navigate resources on their own. Previously, literature has shown that web-based screening has actually led to higher positivity rates on social risk screening, and including a built-in database of services can facilitate resource connection. So in a recent mixed methods study that was done this past year, about 77 participants in the self-navigation group engaged with assistance, and 85% of participants followed up with resources, compared to 14 and 33% in the in-person group. So just showing that the self-navigation can be a great option for people who have the activation and autonomy to do this on their own. We don't necessarily need to be following them through every step of the way. And so lastly, I just want to consider some of the risks and unintended consequences of social determinants of health screening and intervention. As I said, this is happening more broadly now, and some healthcare systems and insurance systems are offering incentives for doing this. So we just want to make sure we're being really mindful and keeping the patients, families, communities that we're serving in mind as we continue to expand. So there's been a lot of recent qualitative work that has elucidated several common themes that illustrate some of the barriers to receiving resources that many families express. I'm going to go through each of these in a little bit of detail, but the first relates to the perception of needs. So that an individual may actually have more pressing needs or priorities in the moment that take precedence over the risk factors we identify on our screeners. So these could be social, medical, or other needs that they'd want to address before addressing whatever turns up positive on the screener. Alternatively, they may actually believe that other families have needs that are more severe than their own and don't want to take resources away from people that may need it more. And as I mentioned before, some parents actually have a high level of activation and want to navigate resources on their own, so don't want assistance from us in the clinic necessarily. And then next, so many cite fears of negative, still on that slide, it's a lot. So many cite fears of negative consequences of screening results as a barrier to receiving assistance. The majority of studies do show that families are not concerned about confidentiality when they complete screeners, but there are still some who worry about how their information could be used and are not comfortable with the results being documented in the electronic health records. So many express fears of being reported to law enforcement, immigration officials, or child protective services based on the results of their screens. And even those who are not concerned about external referrals are still concerned about judgment, stigmatization, or discrimination by their healthcare provider. Interestingly, in 2 studies, participants preferred to be screened by allied health professionals rather than their primary care provider due to fears of judgment or stigmatization. And in many cases, as allied health professionals, such as medical assistants, they may actually look or reflect more of the community's needs, reflect the people in the community more than that of the healthcare provider. And despite our efforts to have more uniform processes and normalizing the practices of screening, this is still, of course, a very sensitive topic. And some parents report feeling shame and having to respond positively to a screen in front of their children or the provider and do not want to respond honestly. And the next category, and last category I want to talk about, are prior and actually current experiences that are often overlooked in the screening to referral process. So parents may already know about resources and may already be receiving assistance and therefore do not endorse needs on the social screener. They may also have had negative experiences with the resources that they're being offered and have had difficulty connecting with that resource in the past. So again, don't want to reconnect. And of course, we know social support programs have really strict eligibility criteria and can be a really burdensome application process, which can also deter parents from applying on their own. And due to limited availability and capacity of services in the healthcare setting, parents report low confidence that the offered resources will benefit them, especially if they have special needs such as language concordance services or medically tailored services. So I know that was a lot, but I just wanted to go over some of the things that have come up in a lot of recent literature that, and again, reinforcing that we need to be mindful as we expand this more broadly. Go to the next slide now. So this slide, this is from the Siren report that I mentioned a a little earlier, SIREN stands for Social Interventions, Research, and Evaluation Network, and they compiled a report in the summer of 2022 that brings together a lot of the recent research in the field. I highly recommend checking this out if you'd like to see what's out there. But the major takeaway from this that is, although there's a lot of research on the topic, especially in the last 5 to 10 years, the published studies are not particularly rigorous. They're typically descriptive, small sample sizes, there's no comparison group. So we really need some more research in this area to make sure we're going about this the right way. And so some of these future directions for research could include measuring the validity of the screening tools we're using, especially in linguistically and culturally diverse settings, performing rigorous assessments of best practices, and making sure we're evaluating patient perspectives as we go along, and then developing processes for meaningful engagement and shared ownership with community partners. So I go to this next slide, which is very busy, but I just want to show that there are many opportunities for future directions. There's a lot we still need to learn, although we've come a long way. So just wanted to show you this quickly. So in summary, as pediatric providers, it's critical that we address social determinants of health in the clinical setting, as these have impacts on child's development and physical health. There are a variety of screening tools that you can use, and it's important that you choose one that suits your practice, and that interventions require different levels of engagement, but linking services can be really helpful. And lastly, it's important that we continue to engage with and learn from our patients, support staff, community stakeholders, and colleagues. So I just want to quickly acknowledge my mentor, Dr. Barry Solomon, who's helped with a lot of this work, and then Hopkins Community Connections, which I mentioned before, which tirelessly provides resources for our families in our clinic. The next few slides are just some references. And then lastly, we'll open up for questions and discussion. I've included my email address if you want to reach out, and a picture of my little one who will be 6 months tomorrow. Thank you.
Amazing. Thank you so much. That was incredible. It was a really perfect overview, sort of the state of the art. And I know we will probably have a lot of questions. I'm also thinking, you know, for my own residents and trainees and colleagues, that this would be an amazing talk. And I don't know, again, we would love to get the references. And I think this is something that every pediatrician needs to hear. So thank you so much. And yes, your son is adorable. So I would love to open it up for questions. And I believe, Jessie, you said that there was a question function. How would you like people to ask questions?
Thank you so much, Leora. Yes, so we have the Q&A feature. So for the attendees, please feel free to use the Q&A feature or the chat option to ask questions. We'll prefer Q&A to make sure that the questions go directly to Dr. Lutz and Dr. McGillner. So that's the way that the attendees will be asking questions.
And maybe as people are, you know, starting with their questions, I can kick off with one. I know you mentioned linking services, which sounds like, and you made a very compelling case for why these are helpful, beneficial. I'm wondering if you have any information about how challenging it might be for clinics to get these services. You know I'm making a case to my institution that this will decrease hospitalizations or improve adherence with well child visits. To me, that's very compelling, but I think often institutions don't want to put the money up front for the healthcare, let's say for the community health workers. So it's a difficult case to make. I think also in pediatrics, like with so many interventions, the benefit that you see is really years down the road. And sometimes it's hard to make the economic case for right now for benefits that are going to happen later on. So if you have any suggestions, how difficult was that to do in Johns Hopkins? Any advice for other practitioners?
Yeah, I think that's all a great point. And I guess one advantage of incentives maybe coming out with Medicaid for screening and intervening on these services, you could take advantage of that to also say, you know, this is this is going to help our hospital system if we have these people to connect, because it's too much for a clinic on their own. I think we're all extremely busy on a daily basis. It's a lot to ask of someone who's already has multiple other roles in the clinic. So we actually didn't have community health workers for some time in our clinic due to funding, but we're able to get a grant to support them, and they help definitely with connecting to families, especially who can't make it into the clinic. So looking for opportunities for grants that are maybe funding outside of your hospital system, which of course requires some work, but will be very helpful in connecting families in the long run. And as I said, taking some of the burden off of people who are very busy in the clinic on a day-to-day basis.
Yeah, that's great. And I think, one of the challenges is, hopefully we're able to go from the grant funding to getting it. The goal would be to have it institutionalized so that your institution recognizes this is really important. This is part of pediatric care. And the other piece of it is really getting the insurance company recognize that. And for Medicaid to say, hey, this cuts down on our costs in the long run, we should cover. The other thing I just wanted to mention, since you did mention CAP for Kids, capforkids.org/New York City is a wonderful resource database. And we're managing it out of Mount Sinai, but we would love if there are resources or information that other sites share, please send it. You can send it to me and I'll send it to our webmaster. We're constantly updating the site, and it's currently New York City, so it's the 5 boroughs. I know there was interest. I spoke with people on Long Island who are interested in a resource database, but we're constantly updating it. We have volunteers who really try to ensure the accuracy. There are a lot of resources on there, applying for WIC, applying for SNAP, linking to Reach Out and Read, other resources for parents. So please definitely check it out. So I want to see if I don't see any questions. Jesse, am I missing them or?
Dr. McGillner. Hi, Sajal here.
Yes.
So actually, we were just realizing that we do have a great comment over in the chat. We can't transfer it over to the Q&A, so I'm actually just going to read it out.
Sure.
Dr. Lutz, if you'd be able to address this, that would be great. And thank you again for such a wonderful in-depth presentation. So this is from Dr. Amy Willever. And she notes, I think some families get frustrated that we continue to ask questions and they continue to answer positive for things that we have little control over. With a large undocumented population and a long wait time for free legal immigration help, just continuing to give them the same phone number is not particularly helpful for them or us. So if you could just address what I'm sure is a common barrier in many clinics, we would appreciate that. Thank you.
Yeah, I wish I had a solution for that too. I think it is really challenging. And that's why it's important to be mindful about what types of questions we ask and not ask about things we can't necessarily provide help for. But that being said, we don't want to ignore, there's a lot of needs within a specific community. We don't want to ignore that too. And so finding ways to help those families that are tailored to what they need. And yes, it might not be public benefit that they don't qualify for, of course, but if there's something else locally that they could be referred to or connected with, that's always helpful. But I agree. I think it's really hard to just give a piece of paper with a phone number on it. That's usually not enough. There are, like I mentioned, many, many barriers to families being able to actually get connected to that resource. And so if you're able to partner with community groups, if there are groups that deal with immigration in your community, it might be great to partner with them and see if they can then, help with a warm handoff to certain organizations that they endorse or work with frequently.
Thank you. I think that's great. And I know, many of us have the same experience. And it makes me think of another question. How often do you currently screen? Because as Dr. Willever mentioned, asking the same questions over and over, but is there a best practice or a suggestion as to how often to screen family?
That's another great question. And that is not in the policy statement. And so I think, when the policy statement was written, 2016, this was not as common of a practice. And now it's happening really commonly. And there's not really a great recommendation for how often we should be screening. It's challenging because on one hand, We want to make sure we're not missing any needs as needs change over time. So it's hard to say they're not static. We want to, make sure we're capturing what people need. But on the other hand, for families who maybe see multiple specialists or, the family comes to the same clinic many times for each of their children, they're going to be asked these questions every time they come, which can be sometimes re-traumatizing, just having to answer these questions over and over again. So I'm not sure we're going to have an answer that comes of this, because it's really going to be on a case-by-case basis, but that would be another important future direction for research to maybe look at what's a good happy medium or just some general guidance, because the way we're doing it now, maybe not, might not be the most current or up-to-date way of doing it based on how often screening is occurring.
Thank you. That's very helpful. I mean, it is for those of us who are doing screening. I don't know the answer, so I'm glad that I'm not the only one. We did get a question. Could you share your workflow on how the screening is done routinely? Which I think is I know every practice does it differently, so I would love to hear that as well.
Yeah. And I think, I think it's great that if we can all share that over time, because I think every practice does it differently depending on, your workflow, how it works. But at our clinic, families are given the paper screener, which I showed you when they enter the clinic, along with whatever other forms are age appropriate. So if it's their developmental screener or if it's a PHQ for an adolescent, so they're getting a packet of forms, and every age this is at every well visit. So they get that packet of forms at the front desk and theoretically should have some time to complete the form, either in the waiting room or when they go back to their room and are waiting to see a provider. And then the screeners are collected by the provider who's seeing the patient, and then positive screens. They will typically have a conversation about a positive screen to make sure, we're addressing the needs appropriately. And then we are fortunate enough to be able to hand those positive screens to Hopkins Community Connection, which is our linking service, who then will follow up with the family. If an immediate need comes up, so if it's something like food, we can also, give them food from our food supply, or if diapers, something like that, we'll give them the supplies too. And so that's typically how we do it. I know a lot of clinics use maybe like a tablet or some digital way of doing it. We don't have that in our workflow at our clinic, but sometimes it's a really nice way to streamline that process.
And can I ask, how do the results get entered into the medical record?
So, and that's another hot topic for debate, is how or if we should be documenting these needs in the medical chart. As I said, these needs change over time, and we really don't want someone walking into a room and have a preconceived notion of a family based on what's documented in terms of their needs in their chart. So we currently, as providers, don't put it in our note. We don't add a diagnosis code, which is something I know some people do, but the Hopkins Community Connection will make a note that they reached out to the family, and they have just started including which needs where they discussed when they reached out to the family. Previously, we weren't documenting in the medical record at all. All of the documentation was happening outside. So this is actually a shift for us because we are being asked to document this.
And are the results of the screening tool does it get scanned into the chart? Does it get entered?
No, so it doesn't. And so for any positive screens, then they, if they decide to get assistance, then whatever they receive assistance for will be documented. But the specific, the screener, once it's done, is shredded with like other PHI, and just whatever they are having a conversation about gets put in the chart in a separate note.
Got it. Thank you. I know every institution, I can just share. Currently at our institution, we were having physicians do the screener in the medical record because we got a lot of pushback that the medical assistants wouldn't have time to do it, or at least even having the medical assistants enter the results of the patient. And we're going to be piloting, starting in June, a new format where we're sending, an abbreviated screener to families through my chart. So for those of you who have Epic, or if you have an EMR, the family will get the screener within 48 hours of the visit, fill it out, choose what they'd like help with, and then the physician will get a notification in their inbox, for those of you familiar with EMR. I can report on that at a later conference. I have no idea how that's going to turn out. We're excited because we knew, for a lot of the reasons that Dr. Lutz mentioned, asking questions in front of the family, physicians not having time in their workflow. There are a lot of reasons, a lot of barriers, when we were doing it our previous way. And we think that at least for documentation purposes, this will be better. But I don't know if anyone else wants to share in the Q&A, if they're doing screening, how they're doing it, if they have any other questions about workflow, because I do think it's a really, really important area. And there was another question. Is there any way this program can be integrated into the migrants program in New York City? And that migrants living in hotels and their children do not have access. So from my own experience, we do have immigrants who come to our practice. I'm sure many of you do, and they're integrated into our program. I wasn't sure if the person who wrote the question was asking about a specific migrants program, or, I mean, clearly, I think if you have immigrants who are attending your practices, many of us are already screening and connecting people to resources. But I do think it's an important point, New York City, at least to bring up. We've been seeing a steep rise in the number of immigrants who've literally, been taken to New York City and left with minimal supports, resources. So I think, this is a good point. And yes, if they come to the practice, yes. So I think focusing on the immigrant population is really, really important.
I see too that we have Francine Cutler's hand is up. Francine, if you want to, we can unmute you if you want to share.
Hi, beautiful people. Hi, I love Reach Out and Read and anyone that has to do with Reach Out and Read. I don't know if you guys can see me. I wanted to show you something. Yeah. You can't, right? Mm-hmm. Okay. Yeah. I don't think they can hear me anymore either. Can you hear me?
We can hear you.
Can't see me.
I'm not Francine myself.
Oh, I wanted to show you what her presentation actually looks like in the making, okay. And I can't show my face on here.
Thank you, dear. Bye-bye.
We can hear you.
If you want to share with us what that looks like at your clinic, that would be lovely.
I'm trying to show you the video. Like, I can't show my face on the screen, can I?
Not in this webinar format.
Oh,
if you could describe it to us.
Sure. So if I'm describing it to you right now, I'm at my East New York clinic location on the second floor, and it's a beautiful, enriched waiting office I have, and it's filled with books and activities and resources and plushed animals everywhere. It has beautiful signage saying treat people with kindness. Everyone welcome here with all the colors of the world. This is a safe space. And then when you walk into this beautiful closet on the left-hand side, you have Reach Out and Read books from 0 to 5 years of age, as well as books that was donated from Literacy Inc. We have chapter books for adults. On the top shelf is educational brand new STEM toys and activities for children from 0 to 18 years of age. On the next shelf, I have clothes, brand new clothing for boys and girls from 0 to 5T. These are pajamas for them. So with a book, you always want to have some good pajamas to curl up to in that great bed. And then if you turn around on this side of my beautiful closet, I have Pampers, wipes, baby formula, bottles, breast pads, breast pumps, Clifford stuffed animals, Kinsa smart thermometers, cereal bowls, men personal hygiene, women personal hygiene, diaper bags, brand new clothing for adult children and parents, pull-ups, the tummy playtime jungle gyms, car seats, strollers. 99% of the things I just mentioned are brand new. We also have like tote bags, brand new blankets and stuff like that. And that's what you will see, PPE, COVID test. Like, it's just a space that when she was talking about it, I was like, oh, it's a perfect opportunity to tell her, yes, those all matter, those things, because a lot of the times when I'm in the waiting area and I get to meet someone for the first time, and then I pull them into my space, they're like, okay, can I stay here with you all day? Because it's so much to look at, but it's also resources and educational stuff as well. And then I have a quick one-on-one with them, and I let them look at my resource binder that I created. And any resources that they want in there, I will print it out, give it to them, put it back in the resource binder for the next person. This allows us not to have any missed opportunities, and also ensures that our patients are actually coming back for their visits, because they know that this is like a place where they can be able to get not only their medical needs taken care of, but their social determinants of health. And in order for them to actually make it to that doctor's appointment, they need to make sure they have food in their stomach. They have, clothes on their back. They have that Uber Health. I also do the Uber Health rides for our patients. So it was crazy when she was saying that. I said, I feel like she's reading my report right now, because everything she said that we should offer or some other organizations offer, because of great partners like Reach Out and Read and other places as well, I'm able to provide not only the literacy aspect, but all the way up to the social determinants of health aspect. And it's a great program.
Oh, thank you, Francine, for sharing that. And Dr. Lutz, Dr. McGillner, I promise you we did not plant Francine in the audience. That was completely organic. So thank you so much for sharing that, and for being so generous with your time today and this morning. I believe we're queuing up for just a brief break before the next segment. Jesse, is that right?
That's correct. We're moving to break. Thank you so much, everybody. And thank you, Dr. Lutz, Dr. McGillner. That was such an amazing and empowering conversation and presentation.
Thank you.
Thank you. Jesse or Nardine, do you want to put up the, back in 5 minutes? Okay. Maybe a screenshot of the agenda. So, I mean, I guess people will know to come back in 5 minutes. That's 5 minutes or self-explanatory.
Thank you so much, Leora. And yeah, I think according to the agenda that we sent out to everyone, we should be back at 10:05, but I think like 10:06 will be okay if everyone needs a bio break. So we'll be back very soon.
So welcome back, everybody. We all hope that you had a refreshing yet quick break. So we're going to just be moving right along with our wonderful program. It is my pleasure to introduce the moderator for our next panel, Promoting Early Literacy Development for Children Beginning at Birth, Marty Martinez, our fearless CEO of National Reach Out and Read National. I just wanted to share briefly and then turn it over to Marty so he could speak more about his amazing work, but that he has had over 25 years of experience as an advocate for children and their families in underserved communities. He brings a wealth of experience in the literacy and nonprofit space, as well as health leadership, and we're very fortunate to have him here today. And I will turn it over to him so he can say a few more words.
Thank you so much. I appreciate the introduction, and thank you for having me here with all of you. I've only been in my role for a little bit over a year and a couple of months, but I think this is the second time I've been at the Greater New York annual gathering. So I'm excited to be back again with everybody and to sort of to be able to be here for this panel, Promoting Early Literacy Development for Children Beginning at Birth. It's a really exciting time for Reach Out and Read in New York, a really exciting time for Reach Out and Read across the country, as we as an organization strive to sort of meet the moment that we're in and meet the needs for children and families across the country. So I'm super excited to be here and eager to sort of engage in this conversation with everyone and the work that everyone's doing. So again, thank you for having me here. I'm joined today in this panel, and really the panel, they're doing the heavy lifting here. So let me just introduce the folks that are here today. I'm joined by Dr. Nikki Sherman. Nikki is the Chief of Research and Innovation at Reach Out and Read, my colleague at the national office, who for years at the organization has been driving innovation and research across the organization and really doing heavy lifting to lift up our model and grow our impact across the country. So Nikki's here to be a part of this panel, so we're excited to hear from her today, as well as Dr. Danielle Erkoboni. Danielle is the Assistant Professor at the University of Pennsylvania, General Pediatrician at Children's Hospital of Philadelphia, as well as the Associate Medical Director of Reach Out and Read Greater Philadelphia. Again, Danielle, a strong partner, not just for the work that she's doing for the field, especially when we think about how beginning at birth, sort of what it looks like in practice, but also a strong driver of research and efforts across Philadelphia and Pennsylvania in general. So super excited to be here, both with you, Nikki, and with you, Danielle, to sort of have this conversation and engage and sort of, where we're at in this work. Reach Out and Read nationally is sort of doing work right now to launch what is a 5-year sort of network-wide implementation plan that we're calling Building Connections Begins at Birth, which is to really ensure that sites throughout the Reach Out and Read network promote early relational health beginning at birth. This is work that's been happening in different places across the country. This is work that's been piloted by the national organization in partnership with affiliates to really begin our model at birth and to really squarely and intentionally focus our efforts to strengthen early relational health. We're really pleased of this network-wide implementation plan to really scale this across the country. And to give you that sense, we're in 6,000 clinics, 33,000 trained clinicians across the country, and really doing all that we can to make sure that we are able to network-wide build this. We're really pleased that Reach Out and Read Greater New York is also strategizing over the next year with plans to implement starting in fiscal year 24. And I know the work that's happening on the ground with the great staff and Emily and team to make that happen and the work that goes into that. So we hope this panel is going to help give you a little bit of glimpse of what's to come and some of the work that's already happening. So I'd like to get started, and I'm going to turn it over to Nikki here. Nikki, I think it'd be great to sort of, talk to folks about why early relational health, why beginning at birth, and how do they connect, and why this is so important. Nikki?
Yes, they are. Thank you, Marty, and thank you everyone for being here. It's so good to see so many people on this call listening in, and that wonderful presentation by Dr. Lutz and Dr. McGillner was just amazing. Yes, why are we beginning at birth when traditionally for 30 years or so we've traditionally started at 6 months, when the original reason was to let's start talking about reading aloud when a baby can sit, on a lap and actually be looking at books. And so the prompting for this, we've been talking about this today quite a lot, the AAP policy statement in 2014. It was called Literacy Promotion, an essential component of primary care. And in that policy statement, there was a strong recommendation to start talking about early literacy, shared reading, beginning at birth. And so reach out and read. If this is the urging of the AAP, let's really look at that. And we started looking into it. It's taken us a long time, obviously, to get to this place where we're officially saying, this is it, we're going to go across the network. But there are strong reasons for doing so. And they connect also with early relational health, which I will come back to in a second. But the first 5 months of a child's life are a time when foundational relationships develop between the parent and the child at an unparalleled rate. There's mutual attention, there's responsiveness, engagement, enjoyment, all of those things which encouraging families to read aloud with their children during that time, and especially to talk and engage with them, which I know you already do, seems to be sensible to start right at the beginning there. Many parents don't realize the crucial role of engaging with their children when they're babies. We hear a lot of people saying, well, I don't think they're listening at that age, which we know they do. And we encourage parents, we say they love to listen to your voice. They love to hear you. And also research shows that mothers during this time, during these first 5 months, undergo the neural changes that support positive adaptation to parenting and the development of the mother-infant relationship. So as we start talking more about the importance of relationships, and as urged by the AAP policy statement, it just makes sense to incorporate those extra well-child visits into our core model. So, and those additional well-child checkups that starting at birth significantly increases the dosage of our intervention at a time when families are most receptive to setting up new routines and when foundational patterns of engagement are established. And then turning to early relational health, there's another policy statement which has also been mentioned already this morning. That's the AAP policy statement, Preventing Childhood Toxic Stress, Partnering with Families and Communities to Promote Relational Health. And that came out in 2021, just after we launched our next chapter. And our next chapter had a commitment to maximizing the potential of pediatric primary care to promote the positive interactions that foster healthy development during the critical early years of a child's life. And so those two also connected in. And in the last 2 years since the release of that policy statement, Reach Out and Read staff and many of our medical leadership have participated in a learning journey in which we started working together to develop an understanding of the role of Reach Out and Read in promoting early relational health. We're not changing Reach Out and Read, we're still doing the same thing. We're still promoting giving books in the exam room, talking with families about the importance of reading aloud, modeling, all the same things that all of you have always been doing. What we're doing is looking a little bit upstream and saying that if we start beginning at birth, and if we start really focusing on those relationships between the parents and caregivers and their young children, then that leads to the brain development that then allows the development of language and social emotional, all of those milestones which we believe Reach Out and Read supports. And so we've had increased interest in early relational health and beginning at birth from clinics and clinicians in our network and from those who fund our work to make this an opportune time to converge these two streams of work into our new project, our new implementation plan, Building Connections Begins at Birth. And we'll talk more about what that looks like. Back over to you, Marty.
Yeah, thanks, Nikki. And obviously, as ever, champions of Reach Out and Read on this webinar and part of this conference know that Reach Out and Read really has been about building those moments that matter, right? And those moments that matter, that's always what we've done, right? So this is sort of, I think, being intentional about how we're creating that, and how the model itself is strengthening that from the earliest times children are engaged with their clinician, and that continuing to strengthen their own development. So Danielle, so we know in theory as the organization's doing this work and sort of how we're combining this work, but what does that actually look like when you think about our model and you think about it in clinic? Danielle, how people make sure that we all understand what it actually looks like?
Absolutely. And I also just want to say thank you so much to Greater New York for having me today. The model of beginning at birth is one that I've had the good fortune of, I think, testing out even into the earlier days. So our team at Children's Hospital of Philadelphia had worked on a research project to help to bring books into the clinic starting at birth. I'd say it was a few years ago at this point, and had the ability to study that via a randomized clinical trial. And what we saw was that those rich conversations were happening even earlier. Families were engaging over a book earlier than they would, even if the books were starting to give out at 6 months. So we knew that power of that book going home really meant something for families. As we begin to roll that out now across all of our sites clinically, I've had the good fortune of continuing that on in my practice and learned a bit that the book is a little bit of a different tool in those early ages, right? When you think about a child in early infancy, the most important thing that we want to emphasize is that eye contact, that back and forth engagement. And sometimes when we talk about that, it can be a bit nebulous to families, right? It can say, how can this tiny baby who isn't so good even at looking up at me yet, or just seems to cry or fuss or sleep or eat, is going to have a return exchange. So bringing the book into the exam room really serves as a tool to facilitate those conversations. We talk about reading aloud while you're cuddling the baby. It's a good time to talk about even, singing or just talking about the thoughts on the top of your head. Many parents appreciate that recommendation in the early days, that their voice is incredibly powerful because they feel like they're learning so many new things. For those of us who are parents, I'm sure you can think back to those early days, especially with your first little one, where you had no idea what was the right thing to do at any given time, really giving reassurance around that time and saying, hey, what you've been doing all along, talking and reading and singing to your little one is really the most powerful thing you can do. And it does help to soothe them. I've had a lot of parents come back to me when I say that and say, I don't really know what to say. I don't have the words yet to have them come out of my mouth. And that feeling compounds for them alongside the other things that they're learning to do for the baby and can be really, really weighing. In that case, the book's a phenomenal tool. Bring it out, show them that those words are on the page, they're geared, they're scripted for you, and they can help to facilitate that engagement, give you something to say. In that case, and you might find that giving the book out in those early days is a little bit more the words for the parents than it is for the little ones. Those is a great time to bring out the books that really are rooted in love and care and the caregiver experiences, the one that really tugs on your heartstrings. My favorite is On the Day You Were Born. And so that helps to give those words to families and helps to root them in that bonding experience that will be one of the many routines they'll learn over those early months that'll go into the trajectory of later infancy, early toddlerhood, et cetera. In addition, we know that as the little one grows, viewing that reciprocal engagement can be a little bit more tangible, a little bit easier to feel. And so that coo or smile, that shared gaze, that powerful connection that happens is really rooted in that. And so modeling that in the exam room, the book becomes a tool to do that. Something that you were doing already can really have that book as really having it in your hand as something that you can go back to. And so I've found that lesson around early relational health, one that we were really hoping to support anyway, having a book to do it has been really powerful. Also, that lesson transcends early infancy. I don't want to keep it in that box of just being in that space. We know that having that connection over the books is something that is an integral moment, as Marty had said, throughout childhood. Those everyday moments are ones that we're looking to start there, but it really can go into the conversation that goes into toddlerhood and those preschool ages. The advantages really are at every level and really can fit for any age and any visit.
Thanks for that, Danielle, and I really appreciate you sort of sharing, like, you know, even when we think about the book and we think about it pre-6 months, that notion that, like, here's how the book is useful, right? And I can understand and even think about it. I've actually heard you talk to other clinicians about it and trying to train folks to think about that, right? And that's an important element of this, right? Because it's still key to our model, right? To Nikki's earlier point, this isn't changing what we do as much as it is enhancing sort of what we're doing. So Danielle, I think that I really appreciate that. So Nikki, part of this is for us to say, okay, so we're going to do some implementation and we're going to be driving this across the country and in partnership with folks like Greater New York. What is National going to do to sort of support and help that implementation happen across the country?
Yes, so National, together with all the affiliates, we're working as a network. We've pulled in as many people as we can who've been trying this out, people like Danielle and her colleagues at CHOP, people around the country who've been testing out some of this work with them, beginning at birth and thinking about early relational health. So working with those and working with a team of 9 affiliates, we've been piloting beginning at birth protocols so that we can create some standardized recommendations for the network, give you some ideas of what it looks like. Danielle's already sort of spoken about a few of these, what it looks like. And so our recommendations are recommending a gift of the book at every visit. We know this is a significant increase in expense, and we are putting together fundraising templates and support, and your affiliate will be thinking about this and supporting clinics, I'm sure, thinking about how we add in these extra books to our model, knowing that getting the money for books can be difficult. We've also revised our online core training to incorporate beginning at birth and focus on early relational health so that every onboarding clinician now is getting the sort of messaging that Danielle's just given you, along with new videos. And we have also developed a supplementary course for those who've already taken the core training. I guess all of you who are on this call now. It's shorter and more focused. You won't be repeating information that you've already done. And we're going to be hosting it also on MyRaw, and it will be trackable so that it'll be like our core training, but a supplementary training, just giving you all the information you need. We've developed new videos again, so that you can try something new, see something new that's specifically thinking about those early ages and early relational health. I have sent over a couple. I'm not sure. Are we able to see those videos? Yeah, thank you.
Mommy, just like what I'm doing, you can talk about everything that you're doing, because sometimes you can't come up with topics to talk about,
Yes.
especially when he's not talking back.
Yes.
So you just talk about what's happening.
Okay.
So you say, oh my goodness, we're gonna look at your belly.
Belly.
And
Belly
make sure
button.
yes, his belly button. And make sure everything is nice and healthy in there.
Yes.
Look at you. And he's letting us know with his facial expressions that he's like, what is going on?
Yes.
So even babies this age can communicate in those ways, right? Those are the cues that he's like, what? I'm not sure I like this. That's what he's saying, right? So it's great to sort of get to know his cues. And
Yes.
I'm sure that you know them already. Like,
Yes.
I can sense that you are kind of tuned into him.
I'm sorry.
Yeah.
Sorry about that.
I'm sorry.
Now, let's see how he does when we flip him over onto his belly. And, you know, kids sometimes don't like this as much because they're so used to sleeping on their backs.
Yes.
So one of the ways to keep them here is to do something that's attractive to them, which is the number one thing that attracts them is you, Mom.
Yes.
You, Daddy, Big Brother. So you can entice him to lift his head up by even showing him these high contrast books like the black, white, and red books, etc. He can breathe, sweetheart. Don't worry. He's stronger than you think he is, right? He can breathe, but we could flip him back over.
Yes.
Aw, and Mommy, he's looking for you to comfort him.
Okay, baby.
Aw. Look at that. Look at that. I love how he just calmed right down when you picked him up. I love how you talked to him.
Yes.
It's beautiful to watch, and it's beautiful, I'm sure, for you to be part of that interaction. And what Big Brother's doing and reading with him, that's all really, really beautiful. As he gets a little older, he'll start to pay more and more attention.
Yes.
Right now, though, he can still listen, right? So when you read to him, it could be anything. You could read anything to him, the newspaper even. It doesn't matter, but he loves hearing your voice. So, you know, Mom, you are such a pro at it. So just keep on doing the stuff you're doing.
Thank you.
I love how you're coaching him on how to read to the baby. It's beautiful.
Look at that beautiful eye contact. That's wonderful.
He's a great boy.
He is.
Baby. What is it?
Tell Mama. Tell Mama more.
You can speak. It's okay. We don't run away.
Yes.
Say a word.
Yes. Oh my goodness.
Then that is so fantastic that is something that he knows and expects of you. He knows that you're the person that kind of talks with him and has those conversations, that he has those connections with in that way. And that's so, so powerful.
High five.
High five. Yes.
High five.
And he even opens his hands for that. Oh my goodness. Caleb, you are blowing me away, my friend. Yes. And so even kind of shifting, if I go, hey.
Okay.
He knows. Hi, dear.
Look.
Oh, he wants all of you, Mama. That's perfect. That is perfect. Fantastic. Excellent. All right. Oh, we don't want that to fall now, do we? Now, what I see that he did here is something often that I know is used to lots of people talking to him, because he kind of tracked that vision over to me, right? And he said, oh, there's someone else to look at over here. Absolutely. Absolutely. And that is a phenomenal skill, you know, to kind of look for at your age, right, my friend? Yes. Yes. Oh, my goodness. Can you move these hips up and down? And up. Very good. Wonderful job. Yeah. What are you doing? What are you doing? That's awesome. So big. Caleb is so big. And as I look up, he's also getting all this great control over his head and neck. And looking back and forth. Yes, my friend. What's going on? What's going on? There's Mama. There he is. Wonderful work.
Thank you. So you can see these are still a little bit in progress, these videos. We've not quite finished them, but they will go into the training. Also just want to note, we know that well-charmed visits are cramped for time, and these videos take about 3 minutes. And the idea is that we're giving you as much information as we can, and use what you can when you see these videos to give you ideas of how to include Reach Out and Read into these early visits. And then we are also putting materials together. So we have created some new milestones. Again, these are very nearly finished. These are hot off the press, along with our group of clinicians who help us develop all of our materials. We've gone through and we've revised the original developmental milestones to incorporate those first visits, and then also to focus a little bit more on early relational health, relational observations, giving anticipatory guidance and modeling guidance for our clinicians. If you want to, you've got the early years here, and you can see as the rainbow goes on. Can we go to page 2? If not, no worries. No, that's okay. Page 2 takes us to the next one. So starting from a year, it'll give you the 18-month visit and the 24-month visit, and it goes on through the rainbow through to green and blue. And so these will be made available along with new bookmarks, new posters, all the new materials that you can use in your clinics to support parents with this work. Back to you, Marty.
Yeah, thanks for that. Thanks for that, Nikki. And obviously, the resources, the tools, the videos, the training, these pieces are critically important to actually have implementation and driving that. I don't want to lose sight of something that Emily put into the chat for everyone, that the Greater New York is drafting a beginning at birth plan into its next strategic plan. And so that folks know that they're working on how to best fundraise and support that. And so I also want to lift up nationally, we're also looking at fundraising, right? That if you expand the number of books, if you expand that leverage that in the model, there needs to be more resources. So nationally, we're also looking at how do we do that across the board to make that happen. So super important part of that. I think the thing that we're also trying to do, and I'm going to bring you back in, Danielle, is make sure we can evaluate the program and evaluate sort of beginning at birth and what it looks like. Aside from being a star in that last video, Danielle, we'd love to, along in the earlier video with Usha, we're packing the stars in for these videos. So I love that. Danielle, I'd love to hear and share a little bit with folks about the evaluation part of this. How do we make sure that what we're doing is actually being evaluated and can continue to be as effective as the model is? So Danielle, you want to share a little bit about that?
Absolutely. And we've had a lot of fun doing it because I hope y'all can see from that video, engaging in, and maybe I'm a biased audience here. I welcome anyone who feels differently in the chat, but getting to spend that time in those newborn visits and have parents be able to walk out feeling like, wow, this really big hurdle that I'm walking through, these early days of infancy, or learning how to grow with my child as a toddler, those focus on bringing it back to parents and really kind of supporting them, and saying, hey, you're doing a wonderful job, and here's all the things and reasons I can see as to why, and supporting those relationships really has been, a fantastic moment for me as a clinician. And through our evaluation, we've been able to really kind of see that, at least within our affiliate, I'm not the only one, in our medical offices, we have sought to both anecdotally and formally work to understand the impact of launching our program beginning at birth. And our clinicians have really been the driving force at ensuring that impact of early relational health really shines through. So across 2022, we launched the Aurora model beginning at birth across all of our medical offices. We provided a live training and the online training that Nikki discussed, provided by National. We, during that time, talked with clinicians formally and informally. We held focus groups across our medical champions, and we did a pre and post-survey across 300 of our clinicians during that time. What we heard was that providing the book at birth gave the clinicians a tool to what they were already attempting to do in the offices. As Dr. Lutz, our keynote speaker, mentioned, we would never want to screen without a plan, right? As clinicians, we don't order a medical test without knowing what we do with that medical test. It's the driving force of what it means to be a pediatrician, right? And so having that book in the office and having the words to say to support that early relational health, to support the development of those relationships, gives us a universal tool for that positive screen. You know, the book in this case is the tool for early relational health. It's the tool that facilitates the conversation that happens over the course of those multiple visits in infancy and those visits that span then yearly through early childhood. That power of shared reading as a positive parenting practice supports the formation of those safe, stable, nurturing relationships that Dr. Moglener talked about earlier. And that is the power of bringing Reach Out and Read beginning at birth. We always want to see that. Those of you who know me know that for better or for worse, I'm a very data-driven person, and I always like to kind of prove what we're looking at. Our affiliate-wide survey, clinicians were really responsive to this. What they reported was that they had more ease of modeling in the exam room. Modeling kind of was integrated more easy by having that tool in early infancy. And that even beyond there, they found that conversation that framed around early relational health kind of bled into those later visits, even though our training was really focused on beginning at birth. Additionally, parents reported hearing those messages more following the launch of that initiative. So when parents reported having what anticipatory guidance they heard in the exam room, those messages around early relational health of talking, reading, singing, eye contact were reported more predominantly. And we additionally didn't see, we saw a high number to begin with. I want to tout my colleagues, but we didn't see that same change in more of the standard Reach Out and Read messages. Read at bedtime, incorporate reading as part of your routine, going to libraries, things like that, where that remains static. So we felt that that training, as well as that launching beginning at birth, was a powerful intervention. Now we do continue to look at this and study this, and we're looking alongside our colleagues across multiple affiliates. We were very fortunate to be able to kind of partner the launch of our survey across 2 local affiliates, or affiliates local to us in the greater Philadelphia area. And we are looking forward to a partnership with those who are launching now in 2 other affiliates. And so really looking forward to kind of continuing to reinforce that survey-based work while we gather this anecdotal data that really drives the story home. And so we are really excited to see more and more affiliates kind of launching into the beginning at birth program. And we welcome any questions or any kind of lessons learned that you have early as you go on that journey yourselves. Thanks, Marty.
Thanks, Danielle, and I appreciate you sort of sharing what you learned from folks. I guess one follow-up question, if I could ask you, is what, you know, as a clinician who's both sort of doing and leading others to try to do, is there anything, I guess, what has surprised you the most about this engagement as we think about beginning at birth? Is there anything that's been like something that was unexpected or that you've learned either through the evaluation process or through your own implementation of the model beginning at birth that has surprised you, or that was sort of something unexpected?
Yeah, you know, I think if I really took a seat back and thought about it, I say, yeah, absolutely, I knew that was going to happen. But the first few visits, kind of getting this off the ground, what I noticed was I was noticing so much more about the attention in early infancy, in that newborn period, that 1-month visit. A few things, both with the book in pointing out or looking to actively point out engagement between an infant and a parent to their voice. I had the fortune of being able to do that in that video because it happened then. And it was around the same time that we were launching it in my offices. And so finding more of that, wow, he really does turn when you're talking. We are also really fortunate, and I think many of you might have, and I was listening to the description of that wonderful area that Francine was describing, and thinking about these great spaces enriched with so many different ways for children to engage. And so we've got some colorful murals above our exam room tables. Those murals, just in pointing out that engagement, I got, started noticing more, wow, the infants are really staring up at those high contrast colors. And so having this kind of focus in my mind of this framework around connection and eye contact really kind of rose to my attention and allowed me to notice it more as we're doing those things, listening to hearts and palpating bellies and, checking hips, reflexes, all the like. Really allows you to kind of get into this space where you say, wow, these things are really happening, and being really observant of them, and subsequently being able to reflect them back to parents. So I think, if anything, just in summary, it really has just shown a light on things that were already probably happening for so long in the exam rooms, but now ensured that they're reflecting back to families and really getting called out to have that powerful messaging going back.
Yeah, thanks for that, Danielle. I think that that's such an important component to think about things that you may, as a clinician, be like, I know that that was happening, but here's a way for me to sort of see it sort of in action, which I think is an important part of it. I want to remind folks that they can put questions in the chat, but I'm going to come to Nikki for one last piece, and then I know there's a question in the chat. But if you have questions, please feel free to put them in the chat. So Nikki, doing this work and sort of intentionally shifting this across the country with the pilot and sort of then the implementation plan, again, because I think it's important to think of the practicality. What do you think is the challenge for us as a network, as an organization, as a program, obviously clinicians here and champions? What is the challenge that we might have to overcome in order to actually sort of center beginning at birth and also leveraging it as a promoter of early relational health? What do you see as that challenge?
I think you've mentioned one of the challenges, Marty, is, money is always a problem, right? Having enough money to have the books, which are the tools which are so important. So that's one challenge. I think also, we know how busy all of you are out there. You are pressurized, and we know that at the moment, through COVID, and then since COVID even more so, how busy you've been, and then it's like, here's one more training to do. So we know all of that, and we know the pressures, and so I guess we hope that the connection with affiliates, with your leaders, with your Greater New York leaders here, that you'll be able to work with them to think about the training to get through it. They are accredited, so we do have MOC and CME accreditation on the online trainings, and in fact we are putting together an MOC4 project as well that you could use, get MOC4 points for doing this work. So we're trying to think of ways of making it easier, but I think probably it's time and money, as always, are the things to actually get it out there. One thing that we know is important is that, in Greater New York, you have an affiliate, you have leaders who can provide the technical assistance. We do have sites out in the world, out in the US, that are not supported by an affiliate. It's probably going to be more difficult to reach those sites and make sure that they're doing it as well. Hence, that's why Reach Out and Read National is strategizing to get an affiliate everywhere that we go, so that everyone has that kind of support. And I could just go straight to answering one of the questions here.
Please, yeah.
From Kathy Grossfeld. Is there a possibility to share the videos to professionals? Yes, absolutely. What we do with our videos is we put them on a playlist on YouTube. We don't make them widely available. They're within Reach Out and Read, but they're on the Reach Out and Read YouTube playlists. You can go in there and find them, and if you can't get hold of them, just let us know. We're happy to share them with everyone. They're branded, so everyone, that's a good way. It gets Reach Out and Read out there. Absolutely.
Great, thanks for sharing that, Nikki, and for not only answering the question and access to it, but to your point around the challenge of money and time as being factors that are part of it. So I appreciate that. I think for folks on the call, and again, if people have questions, we do have a little bit of time before we wrap. I guess I would also continue to stress the, really the desire to connect, beginning at birth and, the early relational health work that we're doing. It really is connected to the entire model that is Reach Out and Read, right? And so it's about making sure that as we connect this and connect the entire dots, that it is integrated and that we think about it in such a way that it's not like, oh, this is a new piece or a separate piece, but really tied to the overall model. I think even Danielle mentioned that we see that, connected to implementation of Reach Out and Read ongoing, right? To make sure that a child at that age gets it at birth and then ultimately gets it over the course of time of our model. So again, I want to just ask one last time, if there are questions, please feel free to add them. Danielle, I wanted to come to you one last time before we wrap and just ask you from your vantage point, this is sort of a big task that we're undertaking, that everyone's sort of undertaking. And from your sense as a clinician, if you were training, as you've done, training clinicians to sort of take it on, what is the opportunity here? Just so we're reminded about, how we started this conversation, why it was important. What would you see as the opportunity for clinicians and sort of building beginning at birth as part of how they do Reach Out and Read?
Absolutely. So with this practice, I think when we did the trainings, one of the, I want to just kind of point out, like, our training was about 45 minutes long, live training. And the point that folks kept coming back to, that we said when we took questions at the end, was largely that we are one, kind of doing something that we have done across the time. We have always worked to kind of point out the impact of parents on their child's development. And so this particular opportunity is giving training, it's giving words, it's calling light to, it's putting a book in your hand around something that clinicians had heard was something that was powerful and had downstream implications for the young child. The point that I was kind of getting back to most readily was that the book really helps to support that. And so those conversations are happening naturally. They're kind of working to point them out. But having that kind of being called to attention, as I had kind of alluded to, and that unexpected type of thing, was it really helps you to notice and to call out more naturally amongst the practice that you're doing in general. And so I absolutely agree with Nikki and with you, Marty, that this does not come without logistical barriers. It doesn't come without barriers of training. It doesn't come without barriers of both providing more books and sourcing and funding, additional books. That is absolutely the case. But I would kind of put right along parallel there is that, as we were going through this process, the lesson learned was that this was something that was kind of practice changing for our clinicians, that really helped to support them in the work that they were doing already, that they were kind of working to do, and really helped to put a message and a book alongside it. And that really kind of was the driving force for ensuring, okay, this is something that we're not just going to commit to kind of off the gate, but is something that we know that we can assure over time. I want to point out, just to kind of loop it back to, from the assets to the concerns, that messaging then going forth was really something powerful to bring back to our funders, to say that this was something that we are so grateful that you have invested in and been able to support for so long. Here is a way that we are integrating that message at a time where routines are being built, where families are already looking to learn so much more about their baby, and we're doing it in a way that makes that messaging more salient, more sticky, more easy to incorporate into flow. And this is how that makes our program X times more important. That's how we began down the pathway of doing the evaluation to begin with, was to say, is this really working? And can we, loop that back to those who have been so gracious to support us in the first place. And that really has been a critical turn to say, look, that the program is that much more powerful. And so trying to kind of address from both sides, but it really has been a game changer in our affiliate.
Well, thanks so much for that, Danielle. And again, we're in the business of building foundational relationships. That is the business that we're in. That is what Reach Out and Read is striving to do. And this innovation is helping to strengthen that. And so thank you for that piece, Danielle. To both Nikki and Danielle, thank you so much for sharing today. And hopefully this gave folks a glimpse of not only this work that Nikki and Danielle have been doing, but the exciting work that is to come here in Greater New York. So thanks so much, and we'll pass it back. Appreciate it.
Hi, everyone. So this is Sejal speaking. I just wanted to say thank you all so much. Nikki, Sherman, Danielle, Erkoboni, what a thoughtful, informative presentation. I think we all benefited and learned so much. And thank you, Marty, for such an interactive, moderating session. I think that was a really great way to engage both panelists with our audience. So everyone, thank you for your continued attention. At this point, we have another 5-minute quick break. We're going to come back at 10:57 and kick off from there. See you all soon.
Okay, I think we have a full team here. So I guess if people want to start coming back to the screens, I just want to say I hope you're having so much fun so far and get ready for a very enriching discussion. So it is my absolute pleasure to introduce the panel of Empowering Families, a critical step in achieving health equity. And I'm particularly excited to introduce our moderator, Dani Herring, CEO of Transformation and Process, author, early intervention ambassador with the United for Brownsville. She's a native of Brooklyn and she's an advocate for her community. Throughout our conversations, I was inspired by Dani's unequivocal dedication to utilizing intentional language when it comes to empowering families and our communities. So I can never really do her justice, but I want to get this started by giving the mic to Dani to introduce a bit of her fantastic work so far, and also introducing our phenomenal panelists who will be here to share resources for families and how we can best intentionally support our communities. So Dani, off to you.
Hello, everyone. Thank you, Nadine, for the warm welcome. It's great being in this space, and this is actually my first time being with you all, so I appreciate and I'm honored to be here. I have been the early intervention ambassador for maybe a year and a half with United for Brownsville, and they were doing amazing work beforehand. But when I came into the space, I recognized that meeting families in a place of engagement and making sure that they understood and they had not just knowledge, but they had an understanding of what the early intervention process was, they would be able to become advocates for themselves. So I've been connecting with families from a place of empathy and understanding. And since then, I feel like we started a parent group where families were able to connect and advocate for themselves. And so many great things are happening in Brownsville since then. And I just want to go right into introducing the panelists. We have a great lineup today. I had the pleasure of meeting them in advance. And first, we're going to start with Anthony Tassi. So Anthony Tassi is the CEO of Literacy Partners, an adult literacy program where BIPOC parents go to transform their lives and create a brighter future for their children through the power of literacy. And he will definitely tell you and share more about himself. Next, we're going to go to Andy Aligne, MD, MPH. He is the director of the Hokelman Center for Health Beyond Medicine in the Department of Pediatrics at the University of Rochester. The center trains young physicians to become leaders in community health and advocacy. Dr. Aligne has been the mentor for over 100 community projects, some of which have led to community-level impacts like the Greater Rochester LARC initiative. Last but not least, Dr. Marilee Fernandez is a board-certified pediatrician and addiction medicine physician who has practiced community medicine for over 15 years. Dr. Fernandez is the Chief Medical Officer and pediatrician at the Center for Comprehensive Health Practice in East Harlem, New York. She has worked with multiple disciplines to provide high-quality, integrated, family-focused care to patients since 2007. And welcome everyone to Empowering Families, a critical step in achieving health equity. And I present to you our panelists. Welcome. So first we're going to start with, let me see.
Yes, thank you. Again, my name is Marilee Fernandez, and I'm so excited and honored to have been chosen to speak on this panel. This topic is one that I'm very, very passionate about and one that's very near and dear to my heart. So CCHP, or the Center for Comprehensive Health Practice, is a nonprofit community health center that's been serving families of East Harlem and the South Bronx for 63 years now. And the founder of this place, Dr. Richard Brotman, was really a true visionary. He wanted a place where families can come to get all the healthcare and services that they needed under one roof together all in one day. So at the clinic, we offer truly comprehensive and integrated care. We have full primary care from pediatrics to geriatrics. We have mental health services, and we also have substance use services, including medication-assisted treatment. We see approximately 3,000 patients a year, and about a third get more than one service at the center. The thing that makes us, I think, so different from other places is that we are truly family-focused and multi-generational. So when we talk about empowering patients and families, we really need to meet them where they're at. That's what it's called. And what does that mean? It really means like bridging that gap between what your expectations are and where the other person is coming from. Because the truth is, when you're struggling with things like mental health, addiction, inadequate housing or unstable housing, food insecurity, your physical health and taking care of yourself may not always be the priority. So let me just give you an example, of a patient, Rosa, a 55-year-old female patient. She comes to see her primary care doctor for an annual physical, and she has diabetes. Now, we all know, as a lot of us are healthcare professionals, that there is a lot of value and importance to doing all these preventive screenings. So best practice guidelines at the physical for Rosa, I'm supposed to give her a referral for her cervical cancer screening, send her to radiology for a mammogram for screening for breast cancer, send her to a gastroenterologist for screening for colon cancer, a colonoscopy. And because she has her diagnosis of diabetes, I'm also expected to send her to a podiatrist to check her feet and an ophthalmologist to check her eyes. That's already 5 referrals that I'm giving to Rosa. And I would feel totally overwhelmed if I had to follow up all those things, even if I didn't have any barriers to care. So what does it mean to meet Rosa where she's at? Well, first, when I'm discussing the referrals, I'd first ask her if she has any questions, because that in itself opens the door for the patient to feel that they have a safe space to tell you some things that they might be having some concerns about. Ask Rosa, okay, do you feel that this is manageable? Because I know it's a lot. And if it's not, then please tell me what you need to try to get it more manageable for you. And ask her really her opinion. It has to be very patient-centered. Okay, so I gave you 5 things and I know you have a lot going on. What is the first thing that you want to tackle? And then try to help Rosa do that. Next slide, please. Okay, I know this slide looks crazy, but I promise it'll get to the point. So the second point that I think was made earlier on in another presentation is when we talk about empowering people and families, we really need to be solution focused. There are a lot of universal screeners that we use all the time to detect things like depression, developmental delays, food insecurity, and other social determinants of health. And more often than not, you'll find that it's not just one thing. It's a lot of things. But what we need to really keep in mind, and they've said before in this conference, is that if you're going to screen, you need to think about the necessary tools that you need to provide to patients and families to address those things. And even if your organization or you don't know of any resources that you have right on site or on hand, build relationships with other organizations, build relationships with community partners, reach out and make network connections with other people and other organizations that may be able to do so. So this crazy slide represents CCHP's integrated model of care. Really, it's merging primary health care and behavioral health and all the other supportive services that we offer. And when I referenced back to it's not just more than one thing, I'll give you a typical case of a patient at our center. Let's take Rosa again. And now she's coming for a sprained ankle. I mean, that seems pretty easy enough, like a easy thing to tackle. But you ask her how it happened during the visit and she starts to cry in your office. And then she tells you that what happened is that she was tipsy and she tripped down the stairs and that's how she sprained her ankle. You ask her another question, and she ended up being tipsy because her partner lost his job several months ago, and now they're being evicted. So there are a lot of things that you have to kind of address there. You know, first, her medical care. You know, she sprained her ankle. You have to try to address that. Then she was drinking a little bit too much that day, and maybe she screens positive on an alcohol use disorder screen. So then do you send her to and refer her to substance use counseling or some other kind of mental health support? Her partner lost his job. So do you provide vocational services or vocational counseling to get him back to work? And then they're being evicted, you know? So are there case management services or some housing services that you can see and refer this family to try to get all those things addressed? And that again is kind of like our model of care. We really try to focus on the whole patient because we always know that there may be more than one thing impacting their own self-care or impacting the family. Next slide, please. And I just wanted to introduce this slide because I really wanted to point out the various ways that Reach Out and Read has really helped enrich our services and add an extra layer of support for our families. And that was highlighted tenfold during the pandemic, like during the quarantine. So we were able to get a lot of donated books, which we distributed in health fairs before. And now these books are being used in our waiting area as well as to create a library for patients waiting. We have our playroom now, which, you know, childcare is such a barrier to care for some parents and caregivers that books are introduced there by our play and learn coordinators. And then, of course, you know, the model, introducing the book at every well visit, you know, is something that we do as well. And I could not be happier to have been, you know, part of this panel and this. Thank you. And that's some contact information if anybody has any questions later.
Thank you for that, Dr. Fernandez. It was amazing. Now we have Andy Aligne.
Hi there, thanks. I'm very happy to be here today talking about this topic of promoting literacy in children, especially in the context of social determinants of health. We got a great intro at the beginning about social determinants of health and trying to address them. Because one of the things that we know from research around the world is that one of the biggest social determinants of health is literacy. And unfortunately, we haven't been doing a great job at achieving proficient literacy in the US, and especially over the years, we haven't made a lot of progress in decreasing the disparities in literacy. And so that's something that, you know, in all of those dozens of projects that I've been involved in that Danny mentioned at the beginning, you know, a whole bunch of those have been about literacy, including a number of them working on Reach Out and Read. But I've gotten more and more interested in literacy, and we've had several grand rounds on the topic. And last year, we brought, next slide, please, Kareem Weaver from Oakland to talk about literacy as a civil rights issue. And I think that that is a good way to think about it. And there's actually a movie coming out with him talking about this now. And so the good news is that we do know a lot about how to teach reading and improve literacy. And one of the big points from that knowledge is that a lot of this starts even before kindergarten. Next slide. And the disparities are there even before kindergarten. So the fancy word for these precursors of reading is emergent literacy. And the things that are good predictors of your ability to read later on that are there already in the preschool years are things like naming the letters of the alphabet, knowing the sounds that go with them, being able to write your name. And so this is all stuff that's not in opposition to reading aloud and enjoying books, but complements it. It's not either or, it's both and. But this is something that can be thought of in that context as something to make these other kinds of interventions like Reach Out and Read even more powerful maybe. And so to help illustrate that, next slide, here's a little pop quiz for you. And so can anybody read what that says? I'll give you a clue. It's the same word over and over again. And so the idea of this slide is that you're all literate folks, and yet because you don't know these different alphabets or these different writing systems, reading that is kind of hard because it's in a code that you don't know. Now, maybe some of you know Klingon or one of these other languages here, but it turns out the word is somebody could read omniglot. Excellent. What language did you figure that out from?
Oh my goodness, I spotted the Arabic right away. But at
The
first,
Arabic?
it's like looking all over the place. I was like, what is going on?
Excellent. Thank you. I've done this many times. It's the first time somebody could read it. So omniglot. Leora, could you read another language?
Yeah, Andy, I got it in Hebrew.
Excellent. Very good. All right. And so Greek is probably the easiest because that's sort of like the root of it. It would mean being able to read every language or speak every language. All right. Thank you all for participating and actually looking at it. Next click. Already did that. All right. Next slide. And so it turns out there's a lot of research. This is, for some reason, kind of controversial, and people talk about the reading wars. I don't really want to get into that. This is a very simplified view of stuff that's been in the literature for years and years. The concept is that it's called decode, the simple view of reading. So just like two parts to reading. So decoding multiplied by language comprehension equals reading comprehension. And it's not an actual mathematical formula, it's a metaphor. But the point is that even if you have wonderful vocabulary development and oral language comprehension, if nobody ever teaches you that decoding part, you're not going to get to reading comprehension. And the decoding part is not natural. It's not something that people generally can pick up on their own. It's something almost everybody needs to be taught. We tend not to remember that because, kids are singing the alphabet song at age 2 and we don't remember that far back. But we needed to learn that. And we need to learn that in order to be able to read. All right, next slide. And so just to emphasize, this is a bunch of both ands. It's not either ors. So you can learn the alphabet while playing, while singing, while looking at books and being read to. You can have your social emotional development and learn the alphabet. Plenty of studies show these are not in opposition, that it actually helps your social emotional development to feel more competent when you get to kindergarten. These are things that can happen at home and in preschool, including in Head Starts or places that use the high scope curriculum or any of the famous curricula. And again, reading aloud and pointing at letters and such go together. Decoding and oral language are both necessary together. And so it can involve books and other kinds of tools. Next slide, please. And so, so this is a project that my team in Rochester has been working on with support from a number of local foundations. We call it the Joy of Literacy Kit. And we've been pilot testing this, giving this out to families at preschools. We're doing it right now at a big early childhood center with about 250 kids. And so this is all the stuff that each family gets. They get the magnetic letter, leapfrog thing for the fridge, and the bathtub letters, number of books, dry erase books and dry erase tablet, and then a bunch of handouts about the library and other local resources. And the favorite thing that I have to admit I never heard of before, but this was from the input from people, is Alphabots, which are like little transformer toys that make the alphabet. People just love that. And so far, we've seen that this is a helpful thing for kids to joyfully learn about the decoding part. Forward, please. So I'm not going to read through this. This is if you want to get into a little bit more detail than just that simple decoding times oral language. This gives you the 5 pillars from the big federal report 20 years ago. And next slide, please. I'm definitely not going to go through this one. This is the reading rope. The point is that, you know, if you want to, as you get into this, it gets more and more complicated, and I don't have time to go through all of that. But that, again, there is no real war of books and language versus decoding. Everybody who talks about this talks about how it's all woven together and you need both of them, and it's both and. Next slide, please. And so, you know, again, this is what it's about. We've been talking about social determinants all morning and reducing inequities. And this is the situation we have now, that unfortunately low-income kids, even with pre-K, even with Head Start, are starting behind at the beginning of kindergarten versus middle class and rich kids. And this is something we all want to work together to do something about. All right, thank you very much.
Thank you so much, Dr. Aligne. Now we're going to move right on, and we're going to be speaking to Anthony Tassi.
Thanks, Danny. Good morning, everybody. I'm so pleased to be here. I just love Reach Out and Read, and looking through the participant list, so many great people are here today. What a powerful group of people and professionals and change agents we've got here today. You know, Reach Out and Read conference is always one of my favorite gatherings of the year. So I'm so glad to see everybody back here again this year, stronger than ever. And Dr. Fernandez, I loved your presentation. I'd like to sign up in your clinic as a patient. And Dr. Aligne, if I ever go back to school, I think I'm going to consider enrolling in your program if you'll have me. I learned a lot from both of you, and so many great points this morning earlier. You know, like took half of what I was going to say has already been said. All the good stuff was already said, so you'll have to bear with me. But I did have 2 other things I wanted to just say here with all of you, and then we'll get into the discussion part. You know, our panel has to do with empowering families. So I've been thinking about this notion of empowering families, and we use this term a lot, I think, in our work, our field. So there's 2 things that really occur to me when I think about empowering families. One is just the word families, right? And empowering families does require us to consider and engage and embrace the whole family, right? So that's a different mindset, obviously. I think I'm speaking to the choir maybe, but maybe it's a little choir practice for us to build our alliances that much deeper. So it's really about the whole family first. And then the second thing about empowering families is really this notion of the strength-based approach, right? So those are the 2 things I really want to talk about for a couple of minutes, and we can move on to the next slide. And I was so moved by the patients that Dr. Fernandez spoke about, and we're sort of this kind of other side of the coin. We have many of your patients. We'd like to have more of your patients, but some of your patients are in our program, and they come to our program, an adult literacy program, Literacy Partners, really to transform their lives. That's why parents come to us, and they want to transform their lives and achieve that super important goal that they bring to the table, which is to create a better life for their children. And they do this through the power of literacy. And so we have classes, we have workshops, we have educational media. But really, when it comes to empowerment, we're just setting the table. We're just like, creating the conditions. It's really the parents that have to do that work, the parents that have to empower themselves, parents that have to do that transformation of their families for themselves. And this is the combination. It's really the generative literacy and language skills, right? And in our program, we combine that in our educational framework. We combine the generative literacy and language skills, the communicative English skills, the survival English skills, the basic reading. We combine that with insights into child development and parenting, because that's, like a primary goal that all the parents have in our program. And then the third leg of our stool is health literacy and connectivity back to the healthcare system. So a lot of our patients, a lot of our students are in similar position to the patients that Dr. Fernandez said. They've just gotten some information from their healthcare provider. It's really complicated. They have to juggle 2 or 3 things. They have to follow a lot of instructions. People are using very big words. Every other word from their provider is omniglot, and I didn't know what that meant. So I was struggling with one of those languages. Omna, what? And the little script that you're writing, or the little info sheet you're writing, it's full of words like omniglot, and it's full of words in these other systems other alphabetic systems that people don't actually understand, right? So that's kind of what we're up against. So you want to move to the next slide? So so going to this first point about families, our work is 2 generation, right? That's our theory of change right here, right? Is to create long-term impact by addressing today's issues today and then preventing tomorrow's from ever occurring. And the way to do that is to build adult capabilities, right? So they can solve problems, achieve goals today, but then they build their children's early learning, they promote their children's social emotional growth, and they facilitate ultimately the school readiness so that there is equity when kids start kindergarten, start first grade, et cetera. And as I look at this, I wanted to just say, given who's in the room, the virtual room here today, that this concept of 2 generation, I feel like there are 3 stages of the work, right? The first stage is really just the awareness, right? And I think absolutely everybody here has that awareness. Other people outside of this room have the awareness that children belong to families, right? That children come in families. Every child has a home. That home does not look middle class. That home does not necessarily look stable. That home doesn't necessarily look the same place every night. Every child has a family. That family may not look a certain way, it may look a variety of ways, but every child. So this idea of 2 generation impact, it starts with awareness that you're not treating a child, you're not educating a child, you're not treating an adult, you're really trying to do something for the whole family, and that there's connectivity and there's issues you need to be aware of, right? And the next stage of this continuum of 2 generation impact is a strategy, right? And that's what Literacy Partners has. We have a strategy. We are an adult literacy program, and our strategy is to focus on parents. And our further strategy is to align curriculum, outside resources, books, experience, teaching and learning methods, all this stuff towards the parent's role within their family, right? And then the last step of this continuum is really the organizational design. Are institutions really designed to serve families as a whole? Is there an intake form? Like how many intake forms do we have? How many different divisions? Do people that are addressing the child's need actually have insight and connectivity, and are they doing anything about the parent, right? Do we have a set of outcomes, right, that are looking at the entire family, not just one individual within the family? So I feel like that's on this continuum, that institutional embrace of 2 generations. We're just a strategy, and I think it's working pretty well for us. But just looking at who the participants are, it's so interesting. Some of you are in, at different places of that continuum, and I think it's interesting for us to think about that. So that's that first piece about empowerment, is really acknowledging the family as a critical unit, as the unit of intervention, as the unit of outcome. Can you move to the next slide? The second message is really the strength-based message, right? And at Literacy Partners, we take a trauma-informed approach, right? And so our work is really rooted in resiliency. So our work is not rooted in education. Our work is not rooted in the science of reading. Our work is not rooted in, whatever teaching. Our work is really rooted in resiliency, because that's the inherent capacity that every parent brings to the table, every child brings to the table, that's going to help them overcome these systemic traumas of poverty, racism, and then the ACEs, the adverse childhood events, experiences that children are in touch with. And so we've broken it down with the help of others into these 6 different domains, and our program really tries to address each one. But I wanted to just also speak to this issue in terms of the strength-based approach, right? And it's tricky when we have sort of institutional or other kinds of setups that are about identifying needs. Like, we're going to try to meet everyone's needs. We're going to try to screen for problems. We're going to try to refer for services, right? But so it's a challenge for all of us to do that good work while still keeping a posture, while still keeping a perspective of the strength-based approach. What are they bringing to the table, right? And so we start at Literacy Partners, what keeps us honest, right, here, instead of saying, oh, they can't read, or, oh, they can't speak English, right? We don't want to be deficit mindset. We want to say, these are the 6 domains of strength that they bring to the table. So we're going to look for areas that they're competent. We're going to look in ways that they feel, where do they feel confident? We're going to build on that. And we're going to orchestrate experiences in our classrooms, in our Zoom rooms, that deliberately build confidence by building out those connections, establishing and building those connections. And these are about people, the connections among people, but they're also connections to services, right? And connections to other resources and other institutions. But I want to maybe stop there, but leave you with this idea that I really think this strength-based posture is really the key. Our people are not the sum of their intergenerational trauma, right? They're not the aggregate of everything that is bad that has happened to them in their lives. We're not every mistake we've made in our lives. We're actually all good people with great ideas, and we have hopes and dreams. And the strength-based approach, if we can really be disciplined about it, is where we can not so much meet people where they're at, but meet people where they hope, right? Meet people where they dream. And in our program, that's been a very helpful shift for us, is to really, again, meet people where they dream, meet people where they hope. What is it they want for themselves and their children? What is that transformation? And then we can create the conditions for them to build their own skills. We can create the conditions for them to get a referral and exercise. We can create the conditions for them to ask questions and get help. But at the start of it, we're not approaching them as someone with a problem. We're approaching them as someone with strengths. We're approaching them with someone with a beautiful, valid, important culture. We're approaching them as agents of their own change. So let me stop there. And I look forward to the conversation and appreciate all of your attention.
Thank you so much. I just appreciate being able to be in this space and have these conversations, because being someone who works on the ground with families directly, a lot of these conversations are not being had. And because we're talking about equity, I want to open the floor up for discussion. And I'm going to actually start with you. I'm going to actually start with you, Anthony, because you said something that was so powerful for me, and that was empowering families, right? And then we spoke about engagement and strength-based approach. And where I want to start is, a lot of times we use words. And I know if you ever had children, right? Children pick up words and know exactly where to put them, whether they know the definition or not. They know exactly where to put them. And I feel like sometimes as adults, we walk into spaces and we hear language and we hear words and we place them and we utilize them. But do we really understand how to activate the words that we're actually saying? So empowering families, for me, I tell my families in dealing with early intervention that it's about empowering them, right? Making sure that they have the authority. Right? So what does that look like when a family comes in? How do you actually make sure they know they're the CEOs. They are partners in this, and they have authority in what you're in your organization. What does that look like? How do you hand families that authority?
Oh, so well said, Danny. I really appreciate this question and also your take on this issue. And I would love for everybody, I'd love to hear 80 answers in the chat. So please add your thoughts if you're so inclined. For us, we think everybody is expert in their own story. And that's kind of where we start right there. We have a technique we use called tags. Find your tags, their talents, assets, gifts, and strengths. We just model, we set up the classroom. Like, people have an idea what a classroom is. And it's usually, with our groups, it's usually a negative idea about what that classroom is, because so many of them haven't been well taken care of in educational spaces. But we set up the classroom to be like a culture of appreciation. And we model that because we have the advantage of being an English language program. So we like our setting up language activities, and we embed into those language activities that perspective, like that. We don't call it you're the CEO of your life or whatever, but I think that's an amazing way to think about it. We just start with like the talents that you bring. You're an expert in your own story. What is your story? Every oppression that people are fighting against has a silencing effect, right? And so every student that comes to our class, we know has a story to be told that they've never had a chance to tell, right? And because we're a language and literacy, like, there's an extra, zing there, because we're sort of working in the domain of literally telling your stories, but more metaphorically and deeper, people get a chance to tell their stories, be recognized for expertise that they have. And oftentimes it starts with love, because we're dealing with parents, and, we absolutely have many parents that can't play this game initially. They can't name anything about themselves that's in charge or where they have agency. So we start with the love they have for their kids, and we recognize that that's unbelievably powerful. And we share some of that brain science with them, that's actually the platform, right? That love you have for your child, that responsiveness you have for your child, that desire to nurture that you have for their child. That's the platform upon which everything good is going to happen. They're going to learn their ABCs. They're going to learn their 1, 2, 3s. If they have that platform, they're going to learn it much better, much quicker, and hold on to it for a lifetime of learning.
Thank you so much for answering that. And I just want to add a nugget to that. I appreciate this so much. The reason why I asked about that is because posture has a lot to do with how families walk into a room. And if they walk into a space that is unknown to them, like walking in the doctor's office, many families would say yes to you, and they don't really know or understand what you're really sharing with them. So changing their posture and allowing them to walk into a space feeling empowered actually opens the space up for them to receive information and feel like they can ask the question, like, I don't understand, or what did you say again? Or can you share more of that? So changing the posture of a family by empowering them is what everyone needs to do when working in human services with families. So thank you for that. Now I want to talk to Dr. Andy. Dr. Andy, I know we spoke about the breakdown of education, right? And like I said, speaking to you, it always pops out early. Speaking, talking about educating children early. When you did that exercise, Nardine and someone else was able to point out something that was familiar to them. Even though we didn't know it, it was something familiar. Language, letters, words are everywhere, right? So seeing something familiar and being able to connect that. How can a family, a lot of work to be done in a household, maybe single mom or single dads, how can a family actually start the process and add that into their normal regimen so they don't feel overwhelmed? What are some simple things they can do that they can add to their schedule?
Yeah, so that's a lot of what the thought process was in developing our kit is, how can these items be user-friendly for folks who are super busy? And so part of the reason that we've got that fridge magnet toy is that's a thing you can put the letters in and it sings the letters. And that children will play with and have fun with and learn at the same time while mom is cooking or doing something else. And then what we found is that people are actually like taking these things with them to the park or to the beach. And on the way, you don't even need a toy or a machine or anything. You can point at signs and you can point at the cereal boxes at the grocery store or whatever. And kids love to learn in general, but they especially love to learn their letter, to begin with, like the first letter of their name. And so it's also empowering for the parents because they see how much fun the kids are having learning. Like you just talked about that, people often have negative associations with classrooms and learning. And this helps to turn it back into fun.
Thank you for sharing that. Thank you so much. Dr. Fernandez, you spoke about so many great things, and I just want everyone to know everything that you guys are talking about, it has to do with care, just taking care of people. So Dr. Fernandez, you mentioned all these things dealing with care, and what came up for me was time, right? So what would you say to some individuals that may share that it's a lot of time to discuss these things? It takes too much time. I don't have enough time in the day to go through, what mom is dealing with or where she's been or connect to the resources. What do you say about that?
I think when it comes to talking about self-care and really making yourself healthy as a parent or caregiver to then be able to provide for your children or the rest of your family, you have to emphasize, I guess, when it comes to adult patients, that if you don't take care of yourself, you can't be the best you can to take care of those that you love. And like, Anthony had said that children are the focus. They are like the nucleus of a lot of families, of a lot of, groups of people. So if you get it to like, we will find time if we work together, just let me give you things that might break down some of the barriers that make you feel like you don't have time, and we can work together for that. But I think focusing it on, your care and the care of your children or the rest of your family, I think it hits home with a lot of the patients that we see, because when you bring it always back to family and children, it like clicks with a lot of people. It resonates with them.
Thank you, Dr. Fernandez. I want to add a part B to that. That place of time is what we share with the families, but what do we say to the providers that may feel like it would take a lot of their time to actually engage with a family that way? What do we share with those providers?
I think that if I could sit and talk about that forever and a day, the sad part is that sometimes there's a lot of structural things that make that visit a lot shorter for providers. And it's not really that the provider has the intention of wanting to make the visit brief, because many of us go into this field because we want to help people, because we want to be devoted to the cause, because we believe in the mission. And we really don't like the fact that we have to document all these things or do all this other stuff. But I think that providers make the time, as best that they can to be able to help the patient and the family, because at the end, that is why they went into the field. That's why they're doing what they're doing.
Thank you so much. Let everyone know that the chat is open. Well, the Q&A is open. So if anyone has any questions, now is the time to share them so I can ask. But I also want to share a little bit about my experience being in the field. And the reason why my questions are very direct is because we have so many resources that are out there. These are amazing programs. But what I've recognized is there has been something lost in translation with communicating that to the people who actually need the resources. So the resources is there and it sounds great. And when we're talking, to our peers and each other, and it's just like, this is great for the family. I want to make sure that families really understand what is happening and what resources are there to actually support them. And in being the early intervention ambassador, there have been spaces where we had to create that community by normalizing the language, even because families, we have different educational backgrounds. We don't know what someone experiences, what that experience is. I know, Anthony, you were talking about trauma. You don't know who's walking in your office. So for me, it's like, we are also humans and we are also individuals. And when we take away the things attached to us, like our titles or our education or the different things like that, how would we now turn around and explain to our child, or how would we now turn around and explain to our families, and what space would we walk into the rooms with when it's our own families? And those are things that I really like to point out, because although we may have understanding and awareness, our families do not. This is not their field. Their field is being the parent, being the family, So we all have something in common, and that is a heart and love. So I just wanted to make sure, we can all see that way. But right now, that's it. If anyone has any questions, is there anything else you guys want to add?
Hi, everyone. Sejal again. And so, this was just such a powerful panel. It's just been such a pleasure and a privilege to sit here this morning and absorb all of this information. And also, I wanted to just note a previous comment that had appeared in the chat from Dr. Sopoulos, just to share with you all, but she made an excellent point that also, even for the parents who are struggling with their own literacy journey, sometimes seeing a child with the book and them getting empowered with their own literacy milestones can be a tool for them to kind of open that door and say, okay, maybe this is something I can do. This is a way for me to bond with my child. So just really interesting how it can go both ways. And I really appreciate that she shared that, because, in my previous professional life, we were often sharing with parents and often with the children that they can be messengers in their own home, so things around healthy eating and, healthy habits. And it definitely, applies to literacy as well. So thank you for sharing that, Dr. Sopoulos. I'm turning it back over to you, Danny.
Thank you for that. I appreciate that. Yes, that's something I definitely agree with, because when parents are empowered, their children get so excited, and guess what? They become cheerleaders. So I appreciate that. I really don't have anything else. I think you guys did an amazing job, even giving the breakdown of what you do, but really showing how you engage with families and meeting them where they are. So I appreciate that. And now I am going to turn it back over to the host.
Thank you so much to our incredible panelists and moderator. Danny, you did such an amazing job. As our team has been emphasizing, this is just the beginning of the conversation. If you have any other questions, we will share the speaker's contact information with you all at the end of the conference. Coming up next, I am pleased to start the resource fair part of our conference. Our speakers will have the floor for about 10 minutes, and then we will open up to questions. Make sure to use the Q&A feature in Zoom. Our first speaker joined Docs for Tots as a full-time implementation specialist. Currently, Pulumi oversees the facilitation of quality improvement initiatives with both pediatric practice providers and early care and education directors. Please join me in welcoming Pulumi Soyemi.
Hi, everyone. Thank you for that great introduction, and then thank you for having me as well. I just want to talk a little bit about a great campaign that we have the privilege of being the ambassadors in New York for, and that's the Learn the Signs Act Early campaign. Next slide. So what is the Learn the Signs Act Early campaign? You can go to the next slide. And simply put, it's a campaign designed to help parents as well as other care providers learn the signs of typical development and act early on those concerns. Next slide. So this campaign launched in 2004, and it is a research-based early childhood public health campaign from the CDC. And its goal is to improve the early identification of children with developmental delays and get them the services and support they need as soon as possible. And one of the great things about this campaign are the free materials and tools that it offers to help parents and professionals track developmental milestones. And usually if you see it around, it's usually the acronym for it is LTSAE for short. Next slide. So the materials, all materials are available in English and Spanish to download, and materials can be ordered for free in limited quantities based on what is available in the warehouse. So on the website, sometimes you might want to order 50 of a specific item, but sometimes they might have 10, but they'll send you that 10. It's just what they have available. And the materials can be adapted and translated and customized to help health professionals, early care education providers, and other service providers work with parents to track the development of children they serve. So these materials are customizable. If you want your company logo on them, you can just reach out to the ambassadors and we can help you order those materials with your label. But they are also available in English, Spanish, French, Arabic, and a bunch of other languages on the CDC website. Next slide. So one of the materials that are used are the milestone checklists. And these are communication tools to help monitor development. And they address 4 domains of development, which is social emotional, cognitive, language, and communication, as well as movement and physical development. And these checklists were recently revised in 2019 to incorporate some of the feedback from its first 15 years of use. And they wanted to make sure that the language was clear, concise, and inclusive, and included milestones that more than 75% of children can demonstrate. And that's just some of the things that they wanted to revise. So the new checklists include open-ended questions, reminders about developmental screening, act early messaging, early intervention screening, and tips and activities for families to do with their children. And the best way to use these materials is to distribute them with the families at every well child visit. It's a good way to start a conversation about child development. It helps parents and families think about child development. Next slide. And if you want more information about the revision process, it can be found at the Evidence-Informed Milestones for Developmental Surveillance Tools, and the link is there. Next slide. So another resource are the milestone moment booklets. And these include complete checklists from 2 months up until 5 years old. And they include activities that you could try at home. There's space to write down questions. And it's intended for parents to use throughout the first years of early development. It helps parents prepare for well child visits and gives you a parent-friendly reference in terms of development. I think that is the older version, but I do have the newer version here. Can't really see it, but those books are really, really helpful, and they do have a lot of information in them for the parents. Next slide. And another resource are the milestones brochure, and these are a parent favorite. It's simple, it's straight to the point, and it can be interactive, but it selects a few milestones at a glance from ages 2 months to 5 years old. And it's just a fun way for parents to track their child's development. So we do know that not all children develop the same way, but it's just some things to look for as a child is progressing in their earlier years. Next slide. Another parent favorite are the children's books, and they do come in 3 different ages. They are available in English and Spanish, and each book includes tips for caregivers on developmental milestones. Next slide. So one of the books, this is a 1-year-old book, and it's about a 1-year-old puppy who's having a busy day, and you get to follow along as his family tries to engage him throughout the day while encouraging his developmental journey. And the book contains lots of tips and milestones that you can celebrate with the child for their accomplishments. So here you'll see that a milestone is a baby pointing to show somebody something that they want. And it also gives a tip for how the parent can encourage that development. Next slide. This is the 2-year-old book, Where's Bear? And this is an interactive book that encourages a tiger and his friends to help find their friend Bear in the forest, otherwise known as hide and seek. So they're playing hide and seek and, working together in a forest so that they can find Bear. The activities are also the same. They do encourage all the different domains of development. And there are different milestones that can be celebrated as you progress through the book. And you'll see, because there's a leaf at the bottom of the page and it'll tell you what the milestone is. So it's really great and interactive for parents to use with their 2-year-olds. Next slide. And this is the 3rd book, which is currently out of stock on the CDC website, but it will be available sometime soon. But this is about a 3-year-old kangaroo who is very excited about everything that they can accomplish at this point in their life. So it tracks development and it tells you all the amazing things that they should be doing as a 3-year-old. And just like the other 2 books, it will show you what to look for as a child grows and develops, and gives you tips and activities that you can do with your parent or with your child to promote that development. So yeah, this is a great book to celebrate 2 to 3-year-olds and how far they have come and how far they have what they have accomplished. Next slide. Another resource from the Learn the Signs Act Early is the Milestone Tracker app. And it's available in English and Spanish on iPhone and Android. And the great thing about this is that you can add multiple children and you can track their development over time. It is more comprehensive because it does have pictures and photos and videos to help you understand the different areas of development. And it gives you as well tips and activities, and it's a way to track appointments as well. So it's really interactive and it's really great for parents to have just so that they can track development over time. Next slide. And this is just an example of a flyer that can be found on the CDC website to promote the Milestone Tracker app. Next slide. And when we talk about Learn the Signs Act Early, there are definitely so many different ways to engage in the campaign, and there's different levels of integration. And we find that as we move up the pyramid, the things closer to the top are better ways to engage families. So we find that the lowest level is passively promote Learn the Signs Act Early materials. And this is just like, giving out a link to a web page or having it on display or just telling them about the Milestone Tracker app. But we find that, as we engage in more activities, the most impactful is directly being hands-on with the parents. So actively working with them and engaging families with the checklist and, talking to them about development and, just having so many more resources to work with the families in order to make sure that a child is reinforced in their development. Next slide. Altogether and all in all, Learn the Signs is more than just the materials, but it's a way to engage families in a child's development and ensuring that there is early identification of developmental delays and disabilities. And ultimately, we like to go with this model that parents are the experts on their children. So having reinforcement, having support, and having knowledge about what healthy development is, and how it should look like will improve early identification of children with developmental delays and disabilities. But also, it also helps to get them the services and referrals that they need in order to support development. I do want to note that developmental monitoring through these materials is very useful, but it should be used in conjunction with screening tools like a standardized screening instrument, because we know that when we only do developmental monitoring alone, only 30% of children with developmental delays and disabilities are caught. However, if we do developmental monitoring as well as developmental screening, there is a 70 to 80% chance of children with developmental disabilities and delays being identified. So it's not only important to just use these materials, but to use them in conjunction with a standardized screening instrument for maximum impact. Next slide. So I encourage you all to take a look at the CDC Act Early website. There are a number of materials on the website that we use to engage families and talk about development. And if you need help ordering, getting your materials customized, you can reach out to the email at actearlynewyork@gmail.com. And if you also have any questions, you could reach out there as well. Thank you.
Thank you so much, Palumi. Everybody here appreciates all the wonderful resources you've shared with us today. As a reminder to our attendees, please use the Q&A feature in Zoom if you have any questions for our wonderful speakers. I do have one question for you, Palumi. Is there a link for sites or programs to sign up so they can get notified if new materials are in stock to order?
I don't believe currently that there is a feature right now for that, but we because we do hold the ambassadorship, we will be able to reach out. If you give us an email, we'll be able to let you know when the materials are available.
Thank you so much. I just want to say I'm a huge fan of the resources because you could open the conversation at a well-child visit, like you said, of referring a child to special services, and it could help guide a caregiver's decision why referring their child to, programs like EI or any other home visiting program. So thank you so much, Palumi, again, for all of the information. We learned so much. We have shared some very helpful links in our conference agenda. So for our attendees, make sure to check them out for more information. Also, make sure to use the Q&A feature to ask any questions. Coming up next, our second speaker is a senior policy analyst for HealthySteps, a program of 0 to 3. In her current role, Elizabeth leads HealthySteps sustainability efforts in New York by working with health systems, key stakeholders, payers, and policymakers to secure long-term funding for service delivery to children and their families. Please join me in welcoming Elizabeth Fernandez.
Hello, everybody. My name is Elizabeth Fernandez, and as Jessie just mentioned, I'm a senior policy analyst at the HealthySteps National Office. So HealthySteps is a program of 0 to 3, and I'm excited to share a bit about our program with you today. Thank you to Reach Out and Read for bringing us all together today to talk about how we all can best support babies and families. I'm grateful to be here. And Jessie, should I? Oh, okay, great. We can go to the next slide, please. Great. So today I'll take you through an overview of our model, then talk about evaluation evidence as it relates to connecting families to services, then share some resources for families that we have, talk about training and implementation if you're interested in the program, and then talk about our network, both in New York and nationally. So HealthySteps partners with pediatric primary care providers to support parents and improve the health and well-being of babies and toddlers so that they're prepared for school and life. And as previous folks on this panel mentioned, parents are the experts. So at HealthySteps, we really focus on strengths of families and really support them in what they're already doing and bolstering how they best support their kids. So the early years of life really set the critical foundation for long-term brain development, health, and well-being. Pediatric primary care teams have a long list of family needs to address in well visits, which we've talked about a lot today. So pediatric primary care is the only system that the entire country reaches nearly all young children. So no other system is as trusted by the community or really as frequently accessed by families and young children for parenting or other health information. Babies' brains grow faster from ages 0 to 3 than during any other point in life. And the connections we make with our closest caregivers during this time set the path for babies and toddlers to become engaged learners, productive workers, and successful adults. HealthySteps is a population-based, risk-stratified model that helps to operationalize and enhance the American Academy of Pediatrics' Bright Futures recommendations. So the HealthySteps specialist, a child development expert, joins the pediatric primary care team to ensure universal screening in the whole practice, provide successful interventions, referrals, and follow-up to the whole family. The HealthySteps specialist addresses common and complex concerns such as feeding, behavior, sleep, attachment, maternal depression, and access to social supports beyond healthcare, and really adapting to life with a new baby or a young child. HealthySteps specialists are trained to provide families with parenting guidance, support between visits, referrals and care coordination to needed community supports, and really all specific and tailored to each family's need. That's very important. The HealthySteps model consists of these 8 core components, stratified by family needs, and allowing families with more intensive needs to receive more intensive services. So the most intensive service is that ongoing preventive team-based well-child visits. So the HealthySteps specialist will join all of those for families who need it. There have been a number of published studies about HealthySteps, but today, to align with Reach Out and Read's conference topic, I'll tell you how HealthySteps increases screening rates and connects families to the needed services. So children are more likely to receive developmental assessments and more likely to have higher rates of developmental referrals. They're much more likely to have successful referral connections to early intervention. And in terms of family needs, families have higher rates of non-medical referrals, which includes referrals for child abuse and neglect, marital or family issues, and other social or environmental issues like housing needs, food, all that sort of thing. Mothers also have significantly higher rates of maternal depression referrals and are much more likely to receive information about resources in their communities. Now I want to talk a little bit about positive parenting and our early learning resources. So we have lots of handouts available for sharing with caregivers. All of them are free and open to the public, and I believe you all should have received links or copies of these resources. And they're all available in English and Spanish. And right now we're working on translating them into additional languages, including Mandarin, Arabic, Haitian Creole, and Bengali. And this image here comes from the HealthySteps First Early Learn handout for parents. And it's designed to increase parents' understanding of typical newborn development and ways in which caregiver behavior can support their baby development. This next slide shares about our positive parenting guidance and information, the QR code, if you can check out what this resource is. And HealthySteps specialists provide parents with guidance, information, and resources that can help them parent through the different stages of child development and focus on being a proactive, positive parent. These include anticipatory guidance, timely discussions about parenting challenges such as safety, feeding, discipline, limit setting. We're having some challenges in my home about that right now, and partnering and problem solving on how to manage them. Identifying and further empowering parent and child strengths, helping parents build strong, healthy attachments and relationships with their children, exploring family risk factors and also buffers of toxic stress, and helping families understand their own history and how it impacts their relationship with their children. The HealthySteps sites and care teams also provide all families with concrete learning resources, including strategies, activities, tools, and/or programs that are specifically designed to help them support their child's early learning. So resources should include a broad array of early learning subjects, such as language, literacy, science, technology, engineering, math, relationships, and social emotional competencies. Many HealthySteps sites also participate in Reach Out and Read, and we value this relationship tremendously. If you're interested in incorporating HealthySteps into your practice, please reach out. In terms of our onboarding process, first we do some preparation support and initial implementation planning. Then there's a 3-part training, all for different practice staff and tailored to different practice staff. And finally, after the training, you have 6 follow-up technical assistance calls to focus on implementation and clinical challenges that might arise. As I noticed in the previous slide, the HealthySteps training consists of 3 parts. First, the what and why of HealthySteps and is designed for the full primary care practice. Second is implementation planning, and this is really designed for the core group who will work on implementation of HealthySteps at your practice. And third is clinical practice, which is a much more in-depth, deep dive for HealthySteps specialists and behavioral health staff with guiding principles and strategies for everyday working with families. This is a list and map of the HealthySteps network in New York, and this is our biggest network in the country, and we're so grateful and excited to be here. And then this is a map. This next map is our national network, and as you can see, we're embedded in 230 primary care practices across 24 states and growing. So I'd love to connect with you. Please don't hesitate to reach out if you are interested in learning more. Thank you all for listening and eager to know if anyone has questions.
Thank you so much, Elizabeth, for your informative presentation of all of the research behind HealthySteps and all of the resources that you guys have for free available to anyone, especially those positive parenting resources. I think they're going to be super helpful. As a reminder to our attendees, please use the Q&A feature in Zoom if you have any questions for our amazing speakers. I did have a question for you, Elizabeth. So one of the many things that impressed me was the HealthySteps practice that you mentioned with family service coordinators who quadruple its early intervention successful rate. For this specifically, does the family coordinator connect with the local EI programs to follow up, or do they follow up with the clinic or site?
Oh yeah, all the HealthySteps specialists in all of our practices have relationships with early intervention, and some practices even have embedded these referrals into their EHRs, which is very impressive, and I know took a ton of work. But yeah, they all work tirelessly to connect with early intervention and have really strong relationships with folks there and work hard to ensure that phone numbers and email addresses of caregivers are up to date to make sure that these connections are made.
Thank you so much. I have a question here for one of our attendees. Rosemary says, this has been a fantastic conference. Since COVID, the issue of death has been an issue. What materials, books do you have with regarding grief, etc.?
That's a fabulous question, and I don't have anything like off the cuff, but I know that multiple practices have developed resources for this specific topic because, agreed, it's been terrible and we need to support families through these really challenging times. So I know that sites have resources, but our national office doesn't have a specific grieving and death handout per se, but we have a lot of talking points around that. And so if you give me Rosemary's email address, I'd be happy to share some stuff.
Definitely. And I encourage everybody to also contact Elizabeth. As you guys can see, her email information is there, and we're going to be sending a follow-up email with all of our panelists and speakers information, just so that if you have any other follow-up questions, you can definitely contact them. We have one more question here. You may have mentioned this, but this is coming from Dr. McGillner. But can the HealthySteps specialists bill for their services at their institutions?
Love that question. And the answer is sometimes, dependingly on who they are. So if HealthySteps specialists are behavioral health providers that have an NPI number, they can bill for services. So licensed clinical social workers, clinical psychologists, marriage and family therapists, they can all bill for services rendered. Folks that don't have a billable licensure cannot, unfortunately. So as a national office, we don't require licensure. So that's why I'm saying it sort of depends on who ends up being the person at your practice. Great question. Thank you.
Thank you. I'll just jump in here. Thank you. That's so helpful because I think it just sort of joins that body of evidence that this could almost support itself. If they are licensed therapists, whether it's a social worker or a psychologist, and they're doing this incredibly important work, and they can bill for it, it sort of takes the burden off the practice and it helps patients. So that's wonderful.
Thank you.
Thanks again, Elizabeth, for your time. This was a very informative session. We have shared some helpful links, as Elizabeth said, in our conference agenda. So make sure to check them out for more information. And also make sure to use the Q&A feature to ask any other questions to our speakers. Our third speaker serves as the project director for the Weizmann Institute's Prescription for Play initiative in collaboration with the LEGO Foundation. She also serves as the director of partnerships and is responsible for stakeholder engagement for the organization. She leads the approach and strategy for developing and maintaining expanding key relationships that are mission aligned to support the Institute's research, education, and policy priorities to advance primary care. Please join me in welcoming Mandy Lam. Just double checking that Mandy is online. See her here. Yep, promoting you as panelist right now. I'm so sorry about that.
Hi, everyone. Sorry about that, but thanks for the warm welcome, Jessica. So again, I'm Mandy Lam, and I'm from the Weizmann Institute and excited to talk about the Prescription for Play program. Next slide. Great. So a little bit more about the Prescription for Play program. This program is a little over 3 years old, but it's a collaboration between the Weizmann Institute. And just a little bit about the Weizmann Institute. We are a research, education, and policy institute that was founded by a community health center, the Community Health Center in Connecticut. And since 2007, we have been doing national work around innovation and research in the primary care space. And so we recently just partnered with the LEGO Group and the LEGO Foundation to really enhance this idea around prescription for play. And so the overarching goal of the program is to make the promotion of learning through play as just a standard part of pediatric care. And really our overarching vision, similar to the other programs that have been shared in today's panel, is really to empower caregivers in their interactions with the young children, really centering around the importance of play and really building social and emotional bonds at an early stage, as we know its impact on the overall sort of healthy development of a child. Next slide. So since we started this program, we are actually rolled out the program in all 50 states, and today have really distributed over 2 million kits. And I'll get a little bit more into the resources that we provide healthcare professionals to implement this program. So what's this program look like? And when I was invited to talk to today's presentation, I had to say I was really excited that Reach Out and Read reached out to us, because we really look at Reach Out Read as a model of really how to embed a program into a pediatric well child visit. And so the concept is very similar, of that we hand out a toy and resources at the well child visit to really encourage play and really empower the caregiver in engaging with play for at least 15 minutes a day. And so really the resources that we have built around this, we have not only the kits that we provide to pediatric practices to hand out as part of the visit, but we have resources for the providers as well. So we have a hub where we house trainings on how to talk about play, the importance of play, you know, modeling what that conversation might look like in the well child visit. We also have other materials that we can provide for caregivers on just tips and tricks on how to play with their child, not just with the brick kits that we provide, but also any sort of types of materials around the house where you can really engage the child creatively in play. Again, the intervention itself is that we hope that it's delivered between the 18 and 36-month-old visit, so at least 4 times over the trajectory of the early childhood period. And again, just we hope to really build out resources as we build this program out more. So we're continually rolling out trainings for providers and additional resources for caregivers and supporting their child in play. Here's just the link here, and it's on every slide in this presentation of how you know, practices can begin engaged in the program. So next slide, please. Again, a little bit more about the materials we provide. So again, we have these cute little duck kits, brick kits that we provide in terms of the toy that we are able to offer at no cost to clinics. And again, it comes with other brochures and materials for a clinic that really sort of encourage the message of the power of play. And again, we also have trainings that go along with this. This year, we'll be rolling out a new toy that we were able to run focus groups on with many pediatric providers across the country who really informed the development of a new animal. So we'll be rolling that out soon this year. And again, we'll be happy to share that with anyone who's interested. So next slide. So in terms of just the program itself, the Weitzman Institute is really looking at this as sort of a newer model and trying to understand both the provider perspectives, but also sort of the impact that it's having on caregivers. And so first, this is just a sampling of a multi-site study that we're doing, a feasibility study that we're doing with this program. And overall, the perspectives from the providers have been just really enthusiastic to be able to incorporate this program into their well child visit. As many mentioned today, there's a lot that providers have to review during the well child visit and many screenings that they have to do. But again, I think for the providers who have really engaged in this program, they're just happy to provide an additional resource, and it's pretty straightforward in terms of how they do that. And they've done it in creative ways. So again, just are happy to have some tools to educate the providers in play. Also, they have embedded it in terms of developmental conversations and assessments, of how they've done that. And then also just, they're really, you know, it sort of lightens the mood of the visit and really has helped them build sort of rapport with the families that they work with. Next slide. In terms of the caregivers' response to this program, and something that we continue to study in terms of how this program is influencing, you know, behaviors around play. But just initial findings tell us that, again, they're reporting that they're spending more time playing with their children. They also have a new perspective on play and sort of the importance of it, or it's sort of also reinforcing sort of what they knew all along, but it just you know, helps them sort of, again, bring it back to what they already knew. They also enjoyed the discussion around play in the well child visit. So again, just sort of another tool for providers to use to sort of build that relationship with their families. Next slide. And then in terms of just sort of reported behavior changes that we've seen through sort of our initial research is that post-intervention caregivers are reporting that they've had an increase in how many days a week that they're playing with their child for more than 15 minutes. Again, they're reporting more minutes played each time they play with their child. And then again, an increase in how often they're playing learning games. So again, this is just initial findings from an ongoing research study that we have on the intervention itself. Next slide. And again, sort of other benefits of the program that we've observed just by implementing this program and rolling this out to sites across the country is just, again, I mentioned this, but an innovative tool to help them assess development of a particular child, again, build trust, and then again, empowered caregivers with knowledge and resources. Next slide, please. And then I would just say, again, this is the conclusion of the Reach Out and Read materials that we have. But in terms of Reach Out and Read, and I know there's other interventions that have been discussed today, one of the concerns that practices have really mentioned while implementing this program is they're like, well, we do Reach Out and Read and we do HealthySteps, and how can we add one more thing to our plates? I would say that our chief clinical officer for our program is a Reach Out and Read champion himself, and we use Reach Out and Read at his clinic. But really, he and others have really used these tools complementary together, and so really they find that it just enhances the conversation with families to both roll out the prescription for play program along with Reach Out and Read. And so really we don't want to water down any other interventions that may be happening, but really this is just an additional resource and tool for families to have as part of the well child visit. But with that, I have my email here if anyone has any questions about the program itself, and the link here to the our website and resources on how to register for the program. And then I just had one more slide. So speaking with Jessica and other planners for this panel, I know there's interest in the community to learn more about health equity and justice, equity, diversity, and inclusion within the primary care space. And I just wanted to provide an additional resource that the Weizmann Institute has. We have a free symposium coming up focused on sort of tackling old problems within the primary care space. And so this is a free resource for others who might be interested in furthering the discussion on health equity and justice within the primary care space. So with that, I thank you all for letting me join today's panel, and we'll take any questions.
Thank you so much, Mandy, for all the wonderful information you've provided us today. We have time for a couple of questions, and we have here Dr. Ulever, actually from Elmhurst Hospital. She's the one that introduced me to Prescription to Play, and she's just commenting how Prescription for Play is so amazing. The families love it, and it's a great starting point for explaining why it's important to do hands-on play with kids instead of offering them a screen. So I just wanted to share that comment with you. And then another comment from Elizabeth Fernandez, who just presented, says, our HealthySteps practices love Prescription for Play and Reach Out and Read. Stronger together, we're all enhancing supports for families.
Yeah, absolutely. And thank you for the feedback. But again, I think it's a program that is a fun program to bring to families. And I think coming out of COVID and just a lot of the stresses that are on the healthcare workforce, I think it's also been a fun program to roll out to pediatricians and other health professionals too. It brings a bit of levity to the practice and the well child visit. So thank you all, and I'm glad to hear there's folks in the audience who are using the program.
Thanks again, Mandy, for this wonderful presentation. Again, I just want to remind our attendees that we have shared some very helpful links provided by all of our wonderful speakers in our conference agenda. So make sure you check them out for more information, and make sure to use the QA feature in our in Zoom to ask any other questions. Thanks again, Mandy, for your wonderful presentation.
Thank you.
Coming up next, we have one more speaker. For a bonus session, please join me in welcoming Genesis Ledesma, Adult English Language and Literacy Intake Advisor at New York Public Library. Passing it on to you, Genesis.
Hi, thank you so much. Good afternoon. Can you hear me?
Yes, we can hear you well.
Hello, my name is Genesis, and I help run an Adult English Language and Literacy program in Lower Manhattan. The New York Public Libraries offer various programs for adults, including citizenship preparation and U.S. history, career services, technology classes, recreational programs, and for informal conversational English classes and English language and literacy classes as well. We provide ESOL classes for beginner, intermediate, advanced, and literacy adults over the ages of 18. We have weekday and Saturday classes in the morning, afternoon, and evening, in-person and online classes as well. Our our next information session will be in 2 weeks on May 15th in the Harlem Library. After the information session, we usually take a test and help the student find a schedule that would work for them. We don't require any proof of documentation, and we do provide the information in other languages as well. All classes provided by the NYPL are free, and we also offer all of the materials like textbooks in class as well. Some of our classes are work for readiness for students who are looking for employment or to better their employment situation by practicing interviewing skills, resume building workshops, and getting them resources. All programming is provided in various branches, usually available to the public on our website and through flyers. All NYPL programs are free and try to remain accessible. I'm in charge of the English classes for adults, but I'm more than happy to connect anyone to any of the other services provided by NYPL. Thank you.
Thank you so much. Oh, sorry, Jessie, go ahead.
No, I was about to pass it on to you, Emily.
Oh, perfect. Thank you so much to New York Public Library and for all of our wonderful resource partners for this incredible presentation. And thank you to all of you for making today what it is, this robust discussion and really wonderful learnings that we're able to share, not just across New York City, but so much larger than that. So thank you for all of your hard work and your participation. We encourage you to keep the discussion going. Contact us or any of the panelists with the information that's provided. For those of you who have already RSVP'd for the event tonight, we look forward to seeing you there. As a reminder, it is closed if anyone hasn't RSVP'd yet, but that's a good note for us to remember for next year that there's enough demand for us to keep growing and keep getting this to be larger and larger. So thank you so much for all of your support and for making this program as strong as it is. We couldn't do anything for our families or these children without your support and engagement. So thank you all so much.